Morning. I'm Joe Cleveland, the president of the Colorado chapter of the American College of Cardiology. It is with great enthusiasm and pleasure that I welcome everyone this morning to the Colorado chapter virtual educational symposium. It obviously seems trite to state that so much has changed during the COVID-19 pandemic, but things have changed with respect to our ability to meet in person. And while I will completely miss the great social interaction that our chapter meeting usually brings with this educational venue, I want everyone to know that our educational committee has assembled an absolutely fantastic world-class program this morning for us. We have chosen to highlight two broad areas: foundational science, and obviously a very timely focus on the COVID-19 pandemic and its effects on the cardiovascular health, determinants of health, and our delivery of health care. Our focus on COVID-19 will feature an incredibly insightful keynote lecture from Kim Williams. Dr. Williams will interweave the social determinants of health, cardiology, and COVID-19. Another highlight, we'll be joined by our current president, Dr. Athenia Pappas. Dr. Pappas will spearhead a lively discussion about how we must stand up and quit standing by, take action to improve our diversity and inclusion as a profession. I encourage everyone to participate. Ask questions. The chat function is live. You can ask questions during chat. Challenge our panelists. Fully engage in this tremendous educational opportunity. With this preamble, it gives me great pleasure to begin our first quarterly virtual symposium with the introduction of Dr. Lavanya Kondapalli. Dr. Kondapalli is an assistant professor at the University of Colorado Anschutz Medical Center. She serves as the director of cardio-oncology. Dr. Kondapalli specializes in the management of cardiac complications of cancer patients. Dr. Kondapalli received and completed her internal medicine residency at the University of Chicago, and she completed her cardiology fellowship at the University of Pennsylvania. She joined our faculty at CU in 2014. And again, welcome, Dr. Kondapalli.
Thank you so much for that warm welcome, and thank you to Dr. Cleveland, Dr. Carter, the rest of the education committee at the Colorado ACC for this wonderful invitation. It's going to be a great morning. I'm very excited. And now let me see how I can share my screen. Okay, let's see. Okay. Okay. Does that look all right to everybody?
Looks fantastic.
Okay, great. Thank you. Well, it gives me great pleasure to talk about a topic that is very near and dear to my heart, which is cardio-oncology. And over the course of the next 20 minutes or so, we're going to review the need for cardio-oncology and what has changed in terms of our appreciation for the most important aspects of cardio-oncology. We'll talk about available guidelines and what we can use when we're in clinic and trying to take care of these patients, as I know that we are all doing. And then also we will focus on some cardiotoxicity of contemporary cancer treatment. We'll dive into both VEGF inhibitors as well as immune checkpoint inhibitors. These two areas will then further be elucidated by two of our wonderful fellows who have agreed to present some very interesting cases, which we'll get to, and which will honestly be the highlight of this talk. So what is cardio-oncology and why does it matter? So really, when I think of cardio-oncology, it is the management of cardiac conditions in patients undergoing cancer treatment and in cancer survivors. And so when you really think about it, cancer, unfortunately, is going to touch all of our lives, both probably personally as well as professionally. And cancer survivors are growing in number, and so it is something that all of us have to become more equipped at understanding, because we will all have to try to help patients who have had either a history of cancer or ongoing cancer. And kind of what are the numbers? So as of 2018, about 30.3 million Americans had a diagnosis of heart disease. And then about 23.3 million Americans had a diagnosis of cancer. And so when I think of cardio-oncology, it really sits in kind of the middle, right where the yellow stars are, of the blend between patients with heart disease and those who also have a cancer diagnosis. And what are the stats? And so truly, as of 2014, heart disease is still, as we all know, the #1 killer in the United States, shortly led by cancer. But heart disease, unfortunately, is still the #1 killer. And the truth is that I will be honest with you, the oncologists are winning the race. So the amount of drug discovery, the what they have been able to do is just really tremendous. And so the overall 5-year cancer survival rates currently, this was of 2020, they are mostly approaching close to 70%. So we always knew that childhood survivors of cancer, the survival rates for kids are probably around 85%. So most kids will thankfully survive cancer. But what's really tremendous is that even among adults, yes, it's not 85%, but 70% for 5-year survival is actually pretty remarkable. And they anticipate that these survival rates will just continue to increase. Thank goodness. Let's see. Advancing. Okay, here we go. And this is actually a really interesting study that came out in 2019, I thought. And this kind of looked overall at SEER Medicare data. So of course there are some issues using SEER data, but what they looked at between the population of 2000 and 2015 was the risk of death from heart disease. And so they took cancer types that from the index cancer itself, the rate of mortality from that cancer was less than 30%. And they kind of saw what happened to these patients. And what I thought was really interesting is that after 120 months from the initial cancer diagnosis, the risk of death from heart disease really starts to climb. And this gets at this idea that heart disease, unfortunately, still is the #1 killer in the United States, and having a cancer diagnosis actually does not protect you from that. Heart disease will still likely be a reason, a leading cause of death as well. And these authors were able to show that short of cancer, heart disease was the most common thing that cancer survivors died of. And this is actually one of my favorite depictions of kind of this concept. And so this was a study that looked at the Kaiser Southern California population. They took all patients who were 2-year survivors of cancer, and then they saw what happened to them. And so on the y-axis is survival probability, and the x-axis is follow-up in years. And what's really interesting, so the folks who had the highest probability of survival at 8 years were those who didn't have cancer and also didn't have any sort of heart disease diagnosis. But the next best group is actually cancer survivors who do not have cardiovascular disease. Then the next group is the non-cancer comparison with heart disease. So something that we all know, but that heart disease, unfortunately, can in some ways be worse than having a cancer diagnosis. And then finally, the group that had the lowest probability of survival at 8 years were those who were cancer survivors as well as also having cardiovascular disease. And this really kind of gets at this concept that when we see patients who have any sort of cancer diagnosis, we have to push past that idea that, okay, well, now you're going to be your oncologist patient, and your oncologist will kind of be your doctor, and that will be the person who will take care of you and be your main provider. And instead, actually, we have to be more proactive and think about, okay, now you have a diagnosis, and because of the way that cancer treatment is, it is possible that your cancer diagnosis may become a very chronic condition, and that we need to continue to be very aggressive about your cardiovascular health and continue to think about prevention, continue to think about continuation of statin, management of blood pressure, management of diet and exercise. That unfortunately, or fortunately, actually, your cancer diagnosis doesn't actually change the importance of your cardiovascular health. And if anything, in some ways, maybe even makes it more important. And that your cardiologist really becomes someone who, just along with your oncologist, you see regularly. And you continue to maintain those relationships. Because hopefully, the data would suggest that patients will survive their cancer to then go on to have heart disease issues and death from heart disease. Well, so now that I've given you my soapbox about the importance of cardiovascular health in patients with a cancer diagnosis, let's talk about what's available with regards to the guidelines. And so, of course, there's been the biggest challenge in cardio-oncology is data, or the lack thereof. And so much of what we have is consensus statements. But what I wanted to arm the audience with was kind of what is available to you, especially when you are in the office trying to help a patient either with a new diagnosis or managing issues that come up as cardiovascular issues come up as they're going through cancer diagnosis. And so this is a question that many of us get frequently, which is, what do we do? I've got a patient who's got some heart disease, and now they've got cancer, and they're going to get a cancer treatment that could potentially be cardiotoxic. What am I supposed to do? Are they safe to get that chemotherapy? So this guideline came out in 2017, and it basically provides us some guidance over how to manage patients. I like this diagram a lot, and this is actually in the Journal of Clinical Oncology, but basically it gives you the continuum. So cancer diagnosis, start of treatment, end of treatment. And then it kind of goes through at different steps, 5 basic recommendations. Who is at higher risk? What can we do before the initiation of therapy? What can we do during therapy? And then what kind of surveillance should we do during therapy? What should we do to monitor these patients afterwards? I will be completely honest with you. This is a very cardiomyopathy focused guideline, and their real focus is on the drugs that we all know, adriamycin, and then also some reflections on Herceptin or trastuzumab, which is commonly used to treat breast cancer. And so some would argue that this doesn't go far enough, but at least it is. I think it also reflects the fact that those are the drugs that we know the most information about from a cardiotoxicity standpoint, and that otherwise the newer drugs, we just don't have enough data to be able to say consensus statement type of recommendations. And then just for your practice, the highlights of this is, I think, who's at increased risk? And so these are the kinds of some of the things that I keep in mind when I'm seeing these patients. So what is the anticipated treatment that they may have already experienced? So many people will be survivors of childhood cancer who then unfortunately get a second cancer. We know that those who have had cancer before are at higher risk of a future cancer. And so if you have any sort of treatment that includes high-dose anthracyclines, and so this is considered doxorubicin greater than 250 milligrams per meter squared. Now, I would argue that this is lowballing it. If you look back to the original doxorubicin studies, really around 400 to 400 milligrams per meter squared was the dose at which we really started to see cardiotoxicity increase. But this was probably lowered with the idea that along with the American Heart Association, that anybody exposed to around 200, 250 milligrams is stage A heart failure. So they are at risk. This idea that there's no safe dose of doxorubicin. Epirubicin is a different formulation of doxorubicin, but doses over 600 are considered to be high dose. High dose radiation, so 30 gray in the treatment field. So if it's either mediastinal radiation or left-sided radiation. This to me actually becomes more important when you're thinking about patients who have had prior radiation. Current radiation techniques really do a lot to do for cardioprotection. So they do breath holds, that's very focused radiation. And so when I counsel patients who are undergoing current radiation, I say that, hey, look, this is based on old data, and that really we do think that the likelihood of long-term cardiac side effects from the radiation way that you're receiving it are going to be much, much lower. I do sincerely think that's going to be true. And then also this combination. So this idea that radiation and anthracycline together potentiate each other. So if you've got lower dose radiation, but in a combination with radiation to the left side of the chest or with to the mediastinum, that we do worry increases risk. And then who in general is at increased risk with lower dose anthracycline and trastuzumab or Herceptin? And then this gets back to those cardiovascular risk factors that we all know. So we do think that even though you may be getting low dose anthracycline, and I will argue that for most treatment cycles for breast cancer, lymphoma, typical anthracycline doses right now are around 300 milligrams per meter squared max. They really aren't, the oncologists are not going past that. But if you get that and then you follow it with a year of trastuzumab to treat breast cancer, then we think that the risk factors that may play into increased risk of cardiotoxicity include if you have 2 or greater cardiovascular risk factors, if you're over the age of 60 at the time of cancer diagnosis, and then if you start treatment with your baseline echo showing a little bit of dysfunction. This can be anywhere from a borderline EF to a prior history of MI to some valve disease. And now to change it up a little bit, we'll ask and also show you some more guidelines. So let's, and we'll see if we can use some audience participation. So patients at highest risk of trastuzumab-induced cardiotoxicity include all of the following except age less than 50, underlying heart disease or hypertension, a baseline EF 50 to 55% or lower, prior anthracycline exposure. Let's see. Any takers? And it's okay if there's no takers too. I guess I'll look to the chat. Okay, so I think we might be getting an answer coming. Okay, well anyway, the answer is actually less than 50 years old. And this kind of came out of an AHA scientific statement that actually is specific to breast cancer. And it's looking at cardiovascular disease and breast cancer, where these kind of conditions intersect. And so in taking care of women with breast cancer and men as well, this is a resource that is available to all of us as well. And then kind of thinking about some of the other resources that are out there. There is a SCI expert consensus statement. So when you're taking care of these patients in the cath lab or dealing with questions about how do I manage their dual antiplatelet therapy in the setting of platelets that are low or anemia, this resource can be very helpful. This came out of MD and the lead authors from MD Anderson, where they kind of address this issue all of the time. But it was a consensus statement with reporters, with contributors from all over the country, actually, and the world. The other resources that we all have is that the European Society of Echo, along with the American Society of Echo, to give us some guidelines of how to manage imaging in patients with cancer and cardiovascular disease. The primary point of this paper itself was emphasizing the importance of global longitudinal strain as a measurement that we should be doing in patients who are receiving any sort of cardiotoxic chemotherapy. They also outline what is an abnormal global longitudinal strain, but then we run into a little bit of a limitation of what do we do with that result. And so I use this kind of as a resource as I'm thinking about imaging in my patients, but in terms of how to manage it, that you will not find in this article. And then there was also a European Society of Medical Oncology came out with a guideline as well in 2019, or 2020 actually. And this goes a little bit past anthracyclines and trastuzumab. It talks a little bit about VEGF receptors, tyrosine kinase inhibitors, which we will talk about as well. But again, most of these consensus statements don't say much about the newer drugs because we just don't know enough to be able to say anything definitively. And then finally, I think this is also really important that there was a guideline that came out from the AHA about the importance of rehabilitation exercise in patients who have a cancer diagnosis. And that overall exercise is very, very important. They've been able to show with both quality of life as well as symptom control in patients who are undergoing cancer treatment. And that also, more importantly, we know that exercise helps cancer survivors. And so this paper proposes this idea that we actually should be having, quite like we do cardiac rehab, cardio-oncology rehab for patients who have undergone cancer treatment. And then finally, the other resource that I turn to often is JACC Cardio-Oncology. This is an excellent journal, I mean, really tremendous in terms of kind of the latest with regards to the most up-to-date cardio-oncology research, especially in light of newer therapies. So to switch gears just a little bit, let's give you a sense of the contemporary landscape of where we are with cardiotoxicity. And this actually is even itself a little bit outdated, but this is from the New England Journal of Medicine in 2016 from Javed Moslehi, who's one of the leaders really in cardio-oncology. And so he put together this kind of update on where we are with the drugs and the cardiotoxic side effects. And so on the top of the table, you'll see kind of traditional therapies, radiation, anthracyclines, platinums, kind of the old chemotherapy, if you will. And then on the bottom, we kind of see these targeted cancer therapies. And that's really the key right now. So when patients have a cancer diagnosis for many solid tumors, and even also now for many of the blood cancers as well, the receptors that are being presented on the tumors becomes very important. And the oncologists are really targeting therapy to be specific to the receptors that they see expressed on those tumors. And so HER2 therapy, or trastuzumab, was the first of this. So HER2 positive breast cancer used to be, unfortunately, had terrible prognosis, but then the development of drugs like trastuzumab that really specifically targeted that HER2 receptor have led to really great results with regards to morbidity and mortality, and really decreased the morbidity associated with HER2 positive breast cancer. Another class, a big class of drugs, is VEGF inhibitors. We'll touch on this a little bit. These are drugs that attack VEGF receptors that help tumors grow. And then tyrosine kinase inhibitors as a big class. It's a huge class of drugs. VEGF inhibitors are part of it. Drugs for CML, which are listed on the top, which Dr. Reddy will review in his case presentation in a little bit, are another class. But this is a huge class of drugs that have lots of different parts of it that are specific to certain receptors expressed in certain types of cancer. And again, more tyrosine kinase inhibitors are listed below. And then finally, immune checkpoint inhibitors, which at the time of this published in 2016, there were only 3, and now you'll see that there are many more. And there are many more down the pipe. So just briefly, let's talk about VEGF inhibitors. And so there's lots and lots of different ones. These are the ones that kind of come to my mind, or the ones that I see very frequently. So bevacizumab or Avastin, Sutent, sunitinib, sorafenib, pazopanib, also known as Votrient, ramucirumab, which is always hard to say. But the reason these come to mind immediately, and this kind of shows you from a cancer standpoint how these drugs work. But basically, these drugs are working on the VEGF receptors that are helping tumors grow. So if you remember, Judah Folkman's major discovery was that angiogenesis was a way that tumors grew. And so in solid tumors especially, VEGF inhibitors have really become an amazing source of treatment. So these drugs kind of work on those receptors that and ultimately prevent angiogenesis from occurring, so that tumors are at least, they stay where they are. Sometimes they also shrink. But as we know, VEGF receptors are everywhere, especially in the vascular system. And so whenever I see these drugs, the common things that I counsel patients on is actually hypertension. So hypertension is the most common cardiovascular adverse event in every single trial for VEGF inhibitors. And also, when you're seeing patients who are getting exposed to these drugs, I tell them actually to start monitoring their blood pressure. Sometimes we see that the blood pressure will rise initially. And so patients who have had no issues with blood pressure out of the blue will start to get extremely high blood pressures, like 180s to 190s. And this is all just related to their drug. Also, too, sometimes for these drugs, patients will be on the drug either continuously, or they will go through a process of ramping up. And sometimes it'll be when they ramp up to a certain dose that you start really seeing their blood pressure rise. Alternatively, sometimes they can be on for 2 weeks, off for 2 weeks. You'll notice that their blood pressure will be really high in those 2 weeks that they're on the drug. And then when they're off the drug, it actually starts to normalize after a couple of days. So whenever I'm seeing patients who are on these drugs, I just tell them as a rule that they should be checking their blood pressure every day. If they start to see rises, I ask them to keep a log of that. And then I actually ask them to send me their blood pressures every couple of weeks. And then also, if they start to notice that between those 2 week intervals, they were starting to get 140s, 160s, 160s consistently, I ask them to kind of let me know sooner, with the idea that I do start antihypertensives. And you should also be checking their urine for protein, because unfortunately they start to spill protein as well. And so I typically will start ACE inhibitors first on these patients, and then amlodipine. But there have been cases where I've had patients on like 4 antihypertensives to manage their blood pressure. The reason it's really important to try to manage it, though, is because typically, and in most cases, we can manage it. But historically, when the oncologists were managing this blood pressure on their own, when they couldn't manage it, they would stop the drug. And that is something that we really want to try to avoid if we can. Because oftentimes, it may be heroic, but oftentimes we can get the blood pressure under control. And these patients, if they can't use this drug, sometimes that means that whole class of drugs is out of the picture for them. And these are drugs that patients can be on for years with very good results. So we really do need to try to push for them to get these drugs. The other side effects to really keep in mind as well, unfortunately, is that cardiomyopathy can occur with these drugs. And, probably the mechanism is related to hypertension. And then also people can have arterial and venous thromboembolism. And so I do keep that in mind. If it even crosses my mind that one of my patients could have a clot in their leg on exam, even if it's not even, doesn't hit all those criteria, that we know that you're supposed to hit before you order an ultrasound, I frankly have a very low threshold to kind of scan for to check for clots and be considerate of these things. I also do routinely do echoes at least once a year on these patients, and definitely at baseline as well. Now, just to switch gears a little bit is to talk about immune checkpoint inhibitor therapy. And I really do think this is a true statement. Any paper that you read on this will say that something to this effect within the first paragraph, which is that immune checkpoint inhibitor therapy is really revolutionizing cancer treatment. It is here to stay. It is getting higher and higher approvals for different types of classes of drugs. And these two investigators actually won the Nobel Prize in 2018. And how it's described is for their discovery of cancer therapy by inhibition of negative immune regulation. And so this is kind of an important concept, I think, in understanding how this works. So immune checkpoint inhibitors. So tumor cells, as we all know, unfortunately are very smart. And so if you look to the diagram to the left, the basis of how immune checkpoint inhibitor therapy works is that you have to kind of take a step back and realize that what tumor cells did was that they took T cells, our native T cells, and tumor cells kind of hijacked the receptors on our native T cells that are supposed to help the tumor cell or the T cell kill the tumor cell. So, and this has happened, when cancer, from the beginnings of time, how cancer has kind of evolved to hijack our own T cells' ability to kill cancer. What immune checkpoint inhibitor therapy does is it actually blocks the receptors that the tumor cells hijack from our T cells. And so by blocking those receptors, and the common ones are CTLA4, PDL1, PD1, what we've done is actually we've been able to then get our T cells back so our T cells can then start to kill these tumor cells. These are the currently approved checkpoint inhibitors. So this is as of like 2020. And so just 4 years ago, we had 3, ipilimumab, pembrolizumab, nivolumab, and now we've got 4 more. And there's honestly more and more coming in clinical trials. But this is, and the approvals are for not only solid tumors, but also blood tumors. The approvals just keep increasing for these, where these drugs have use. Now, the most common thing that happens with these immune checkpoint inhibitors is that it's trying to harness your immune system. And so when that happens, people are getting immune reactions. And so these are commonly called immune-related adverse events. And the simple approach of how I think about this, honestly, is that you take any organ system, you add an itis, and then that can be a side effect related to these immune checkpoint inhibitor therapies. So for example, thyroiditis is really common, hepatitis, myositis, vasculitis, myocarditis, which we'll talk a little bit about. But the most common ones that people will see will be hepatitis, thyroiditis, and colitis, actually. And so then, we initially thought that kind of the biggest things were going to be kind of the GI tract or the endocrine system. But then when these drugs got approved, and it was actually once these drugs started being used in the real world, that the cardiotoxicity associated with checkpoint inhibitors was truly identified. And so these were the first 2 papers that really presented this. Both came out in 2016. One was an international study that looked at about 9 patients who they recognized that, hey, these patients all have this myocarditis, and we think it's all related to the checkpoint inhibitor that they had received. And then perhaps this paper got actually more splash, which was in the New England Journal of Medicine, where they had 2 patients that received combination therapy, and they reported on fulminant myocarditis with this combination of ipilimumab and nivolumab, in this case to treat metastatic melanoma. What the authors in the New England Journal paper did, though, was go further, and then they said, hey, look, let's go back to the Bristol-Myers Squibbs database, and we want to see how much myocarditis was there. And what were the connections? In this pharmacovigilance study, could we find that there was any connections of who would get myocarditis? They found that overall, the rates were pretty low. So about 0.3% of patients in their pharmacovigilance look at the data had some myocarditis. And that also they found that, hey, maybe there is a connection between patients who get myositis first and then subsequently develop myocarditis. And that's what's presented over here. And so then they went back further. So this author went back and looked back at all the melanoma trials and all of the trials that used ipilimumab and nivolumab and pembrolizumab, which were the first 3 immune checkpoint inhibitors, and said, let's look at all the phase 3 trials and let's see how much cardiac side effects really are there. Is this really something we need to worry about? And when they looked at all these trials, they said, hey, look, there's really not that much. I mean, some cases had 0 and some cases had 1, and it was like hypertension or hypotension. It was nothing really significant. We don't really have to worry about this. But the real truth of this, honestly, is that cancer trials are looking for cancer endpoints. Their endpoints are overall survival. Their endpoints are cancer-free progression. They're not looking, nor really, one could argue, do they really have to be looking for cardiovascular side effects? And so that's really perhaps why we never saw anything. And so authors have now, prospectively looked at this. So this comes from 35 patients across an 8-site registry across the United States, saying, okay, well, these are 35 patients who had myocarditis. How did this present? What did it look like? And so just to help us as we potentially consider this in patients that we're seeing, these authors found that patients who actually truly had myocarditis often had an abnormal EKG at presentation. They had an elevated troponin at presentation. Their BNP was elevated at presentation. Their EF actually could be normal on echo. And so, when I think you're seeing a patient who had a checkpoint inhibitor therapy, I always check a troponin if they're having any sort of cardiac symptom, because unfortunately it can be myocarditis. And then also these authors who did a different pharmacovigilance study looking at safety reports from the World Health Organization found that there's actually probably a spectrum, that this isn't just fulminant myocarditis that patients can get. They can get vasculitis, they can get pericardial disease, and that there can be a spectrum of kind of how these checkpoint inhibitor cardiac side effects occur. And that most importantly, actually, that they're most likely to occur kind of within those first 90 days. So that I do use. It doesn't mean that I don't check troponins on someone who's been on a checkpoint inhibitor with new AFib. I do check troponins, and I have identified myocarditis late. But at the same time, I think that your index of suspicion, the data would say, should be highest in that first 90 days, perhaps, that this could be a side effect of the checkpoint inhibitor therapy. And so just in conclusion, so cardiovascular disease is a leading cause of death among cancer survivors. Guidelines exist, although care is nuanced, mostly because of a lack of data that we have. And that common pathways in immunology in the cardiovascular system likely explain cardiotoxicity of contemporary therapy. And also, just as a small plug, you'll be hearing more about this, is that we are going to start a cardio-oncology case conference for the entire state of Colorado. It'll be semi-annual, it'll be virtual, stay tuned. Really, we want this to be an opportunity for you to bring your cases that you maybe, or you're scratching your head about or thinking about what should I do, and just, collectively talk about different options for strategy. One of the biggest things about cardio-oncology is that it's extremely collaborative. I talk to oncologists more than I talk to cardiologists in a given day. And it's because it's not clear, it's not black and white how we should be managing these patients. Thank you very much. And please be in touch with me with any questions.
Okay, on to the case presentations. Let me just share my screen. Dr. Kondapalli, I think you need to stop your screen share for me to be able to start. Thanks.
And actually, Dr. Parr, let's give Dr. Sherman a chance to introduce you.
Oh, okay.
Dr. Jessica Parr is a second-year fellow at CU Anschutz Medical Center. And just parenthetically, she's been an active participant in the chapter and has, for the past 2 years, participated in the legislative conference. She's a native of Connecticut, but now loves Colorado and has been here for 12 years, I believe. Dr. Parr.
Great. Well, let's see if I can get this shared. Okay, is that looking normal to everybody here?
Super.
That's great.
All right, so I'm presenting today a case of immune checkpoint inhibitor related myocarditis. And again, I'm a second year fellow at the University of Colorado. So my case is a woman that I saw a couple years ago. She's a 71-year-old woman with diabetes, hypertension, and also locally advanced melanoma of the scalp. She was previously treated with pembrolizumab and more recently with ipilimumab. And she presented to the ED with weakness and vomiting and was found to have the following presenting ECG. And as you can see, there's a wide complex tachycardia without evidence of AV association concerning periventricular tachycardia. In terms of her relevant data, her troponin was 2.91 at the time she presented. She had elevated aminotransferases. Her ALT was 849 and her AST was 510. Her serum creatinine was 2.49, up from a baseline of around 1.1, and her BNP was 1638. A transthoracic echo at the time showed reduced LVEF with EF visually estimated to be 30 to 35%, but she was in ventricular tachycardia at the time of the echo. Of note, she was a little bit hypotensive at the time. I think her blood pressure was 90s over 50s, and she had altered mental status, but was still, not so unstable that she couldn't talk and kind of interact with us. Interestingly, her ventricular tachycardia was refractory to both cardioversion and anti-arrhythmic drugs, including amiodarone and lidocaine, all of which were trialed in the ED. And it was occasionally bidirectional. It had two predominant morphologies, both of which are illustrated here. Unfortunately, the tele strips of the bidirectional VT have been lost to time, but this is a good example of kind of what it looked like. And given concern for an ischemic cause, she was taken to coronary angiography. As you can see here, she has a left dominant system. She has mild non-obstructive coronary artery disease with a 40 to 50% lesion over here in the LAD, but no obvious cause for her elevated troponin and ventricular tachycardia from kind of an ischemic standpoint. She was then admitted to the cardiology service, and because her presentation was 13 days after starting her second cycle of ipilimumab, which is the anti-cytotoxic T lymphocyte-associated antigen 4 antibody, like Dr. Kondapalli mentioned, a diagnosis of checkpoint inhibitor-related myocarditis was suspected. She was started on high-dose steroids within hours of her presentation and mycophenolate the day after. And her mental status improved. She converted to sinus rhythm, and her EF improved from 30 to 35 to 55 over the course of 8 days. Despite improvement in her cardiac function, however, she deteriorated over the subsequent 3 weeks that she was hospitalized. She developed sepsis with P. acnes and also several gut bacteria. She had renal failure requiring CRRT, liver failure, and disseminated intravascular coagulation. Unfortunately, she died 22 days later after her initial presentation. Fortunately, the family said that we could do kind of an unrestricted autopsy, and that revealed lymphocytic infiltration throughout the myocardium, which is consistent with immune-related myocarditis. The slide on the left is from the right ventricle. You can see lymphocytic infiltration there. The slide on the right is from the left ventricle. So it was pretty widespread. So kind of the learning points for me were that, I didn't know very much about immune checkpoint inhibitors at that point in my training. And I've now learned that they have really improved outcomes in cancer treatment, but can have a variety of adverse effects due to aberration and activation of autoreactive T cells. And myocarditis is very rare in patients receiving a single agent, but carries significant morbidity and mortality. And as the use of these immune checkpoint inhibitors grows, just as clinicians, being aware of the potential cardiac side effects can lead to kind of our recognition and prompt treatment and then improvement in cardiac function. So this was a great learning case for me. and I think brought up a lot of good points.
Thank you very much. Dr. Kondapalli, do you want to comment or do we want to go to the next case?
Yeah, oh, tremendous. Yeah, I think just for the sake of time, we'll go to the next case. But maybe one question for Dr. Parr, which is, I'm so glad that you mentioned the importance of bringing steroids and steroids early. And so can you tell us a little bit, did you, the idea of steroids in someone who could be having a heart attack is always very concerning and a kind of a source of great anxiety. So do you remember how you timed it? Did you cath and then do the steroids, or?
Yeah, so the patient, we were managing in the ED kind of with the emergency team. We decided at that point with the refractory VT that we'd go straight to the cath lab, given her elevated troponin. And then after we saw that this was not ACS related, that's when we started the steroids.
And just briefly, what was the basis of mycophenolate?
That was a suggestion from one of the oncologists just for additional immunosuppression kind of in the setting of presumed, lymphocytic myocarditis. Okay, let's go to the next case. Dr. Reddy is a second-year fellow at the relatively new program at Parkview in Pueblo. He's a native of Georgia, but now settled into Colorado. Dr. Reddy, your case.
Thank you, Dr. Sherman. I hope you all can hear me. So let me just share the screen real quick. Okay. Can you see the screen?
Yes.
Yes.
Alrighty. So let's get started. So I want to thank Dr. Kondapalli for allowing me to present this case, and thank you, Dr. Sherman, for the kind words. So I labeled this a friend and a foe because, as Dr. Kondapalli said, these drugs are really helpful for oncologists, but they can also cause a lot of cardiovascular side effects. So we'll dive into her case. She's a 70-year-old female. She initially presented to the cardio-oncology clinic for initiation of ponatinib, which is a tyrosine kinase inhibitor for CML. At that time, as you can see, she had hypertension, hyperlipidemia, that was well controlled, and echocardiogram, the baseline echocardiogram, the EF was normal. She also did have chronic kidney disease. She has CML, obviously, and had been treated prior to ponatinib with other TKIs, as you can see here, including nilotinib, imatinib, and dasatinib. So you'll be hearing a lot of those. Her medications included atorvastatin. She was on meloxicam and estradiol and diltiazem. The drugs were changed. We discontinued the meloxicam and estradiol for potential side effects of arterial thrombotic events. But unfortunately, a week after starting ponatinib, she presented with focal deficits and was diagnosed with an ischemic stroke. The distribution was in both cerebral hemispheres, so it was thought to be cardioembolic. The transesophageal echocardiogram did not show any evidence of any mural thrombi. There was no presence of AFib. She was monitored for 30 days post. Now, the reason we want to talk about this is, like Dr. Kondapalli mentioned, the oncologists have clearly won in this battle. The tyrosine kinase inhibitors really made a big difference. As you can see in these studies, the 5-year survival was close to 70% in CML once TKI was started, compared to no drug prior to that, 17%. So it's pretty remarkable, the change that has occurred. So we want our patients to be on these drugs. So why do we, as cardiologists, care about these drugs? Well, they can cause ischemic heart disease, peripheral arterial disease, and, as you saw in my patient, cerebrovascular events. Some of the pitfalls we need to understand before we dive into what these side effects mean and what drugs cause what side effects are to understand that these clinical trials, again, as Dr. Kondapalli mentioned, their main focus was to look at survival rates. And they really excluded a lot of patients that did not have, underlying heart disease. So really, our patients are underrepresented in these trials. even so, as you can see in ponatinib, arterial occlusions in some studies occurred in at least 35% of the patients. That's quite high. 9% of the patients in the PACE-2 trial, ponatinib, they had LV dysfunction. And cardiomyopathy was one of the main problems with nilotinib and bosutinib. I hope I'm pronouncing these drugs right. We should also think about pulmonary arterial hypertension, and really hypertension alone, as Dr. Kondapalli mentioned. 68% of the patients that had normal blood pressure to begin with, after starting the drug, had increased blood pressure. So that is a significant amount of patients. And remember that these clinical trials did not include patients that already were suffering from underlying heart disease. So as you can see, the 5-year follow-up is quite remarkable how many people develop pulmonary arterial hypertension and hypertension alone. Now, PAH has been closely related to dasatinib, and hypertension has been closely related to ponatinib. Patients also develop DVTs. 6% of the patients did, pulmonary embolism. And a big thing is also hyperglycemia. And I'll get into why we need to understand what the side effects of these drugs are, because that's how you'll have to manage these patients. So nilotinib, 41% developed hyperglycemia. That's quite high. And also, as you can see, hyperlipidemia was a big problem with nilotinib as well. 1.75 times more likely to have hyperlipidemia that had a normal lipid panel to begin with. All right. So why do we need to know all of these things I mentioned in here? The reason for it is because when a patient comes to you and their oncologist is starting them on a drug, you should be able to, one, guide them along, make them understand what the side effects are. At the same time, risk stratify them. Well, who are the patients that are going to be more likely to develop this? Who should be aware of the side effects? So a good checklist would be, first and foremost, is making them aware of what can happen. This will go a long way if we do have a side effect. This can also go a long way in order to patient to get to a hospital, to get care immediately. So that would be the first thing on the list. The next thing would be blood pressure control. Obviously, as you see the list here, A, B, C, D, E, you want to control their hypertension if they do have any. If they don't, to monitor their blood pressure frequently if you're on these drugs. Cholesterol is important. You want to screen their you want to look at their lipid panel. You want to make sure if they do meet criteria according to ACV risk score to start them on any statin drug. Hyperlipidemia is a problem. Diabetes is a problem, like we mentioned. 41% of the patients did develop hyperglycemia. So you need to monitor their glucose. And of course, exercise is recommended. But I think the biggest takeaway is counseling your patient and making them aware. And you'll see why that makes a difference in this patient. So back to our patient, the reason I mention all these things is because we did do this when we first saw her. She was started on aspirin. There was an ABI ordered that didn't show any significant problems. She was also counseled on the side effects of the drug. She was informed that arterial thrombotic occlusions can happen in ponatinib more frequently than other drugs. She was changed to a different statin due to drug interactions, and baseline A1C was obtained, baseline lipid panel was obtained. Estradiol was discontinued for obvious reasons because it can increase your thrombotic risk. Unfortunately, in spite of doing all of this, she did develop an ischemic stroke. But I think the biggest takeaway was that she was aware that this could happen. So she recognized the focal deficits immediately and presented to the hospital. And fortunately, she was not left with any residual deficits and she recovered. So follow-up, she obviously ponatinib was discontinued, unfortunately for her, but she had been tried on interferon before without any CML progression. So that was resumed by her oncologist. Now, in summary, I know that was quite quick, but I want to get to the key points that I think we should take away. Even if you're an internist or a cardiologist, it doesn't matter. You should understand that these risk factors exist because as Dr. Kondapalli mentioned, you will see a lot more patients on these drugs as incidence of CML might progress. So some of the things to take away from my presentation was nilotinib, if you're going to start that, you should really be aware of the incidence of hyperlipidemia and hyperglycemia. It's quite high, almost half the patients. So counseling them, following the lipid panel, and following their glucose is quite important. Pulmonary arterial hypertension, to recognize that that is a side effect of dasatinib is quite important. So if somebody presents to you and dyspnea, so to think about that in the back of your mind. And panotinib, obviously, in my case, arterial occlusive events are quite high. So counseling the patients, and like Dr. Kondapalli mentioned, having a low threshold to order any tests that are necessary. If you're suspecting DVT or a PE, do not hesitate to proceed forward. So, yep, that's my case. Thank you.
Thank you, Dr. Reddy. That was outstanding. Really highlighted.
Yeah, I was told I had 10 minutes, so I kind of flew through that. Sorry about that.
No, that's great. We're on time, and we got about 10 or 11 minutes for questions and discussion. Let me throw out a quick question. A cardiologist more than 10 years out of training have had their cardiopharmacology greatly tested. We've added direct oral anticoagulants. Now we have thrown at us SGLT2 inhibitors. And now you're throwing a whole family of oncology drugs. What do you say to cardiologists as they get overwhelmed with just the pharmacology they're dealing with some of these patients?
Yeah, no, it's a great question. To be honest, I myself, was not aware of these drugs before I was going to present this. So I think the answer to that would be just to be aware of at least the main points from these trials, is to be aware of the main side effects that these drugs can cause, and just counseling the patients. And I know it's hard to keep up with the drugs, but maybe understanding that a class of drugs can lead to certain side effects would be a good way to start. I don't know if Dr. Kondapalli could help with that.
Actually, I think that's a great answer. The other thing as well is that I have found my partners. And so I realized that it's too much for me. I struggle. I mean, I know that Dr. Reddy and Dr. Parr are better with, and many of the folks who are on this call are much better than I am about managing people's diabetes. I feel like personally, diabetes is something where the management has really changed. I know what I should be doing, but I don't feel like I know how to properly manage patients for it. And so I really find that I found my partners, if it's the patient's internist who can help just manage that diabetes, I will take care of the blood pressure and the cholesterol and all that other stuff that I feel more comfortable with. And then I have found, and then when the cases get a little bit more complicated, I have my go-to endocrinologist. I have my go-to lipid specialist. And I also have a whole cadre of my go-to interventional cardiologist and my go-to electrophysiologist, because with all of these things, it's not only that, absolutely, the drugs are a lot to keep track of. So I feel like my job is I can keep track of the cancer drugs. But not only how do I manage the other drugs that patients should be on, and then also I have my go-to pharmacist, because the drug-drug interactions are huge. And so that's the other piece of it, where we actually can cause harm to patients if we don't really understand the interactions. And the biggest one I run into, honestly, is the statins. Is really, like, many of my patients are not on atorvastatin or rosuvastatin, even though we know that's what they should be on. And it's all because of the drug-drug interactions. So I found my friends, and then also I find my team, because even doing procedures in these patients is complicated and not without risk. And so you have to find your partners who see the greater good and why they're, and feel comfortable doing that.
Yeah. Is Ruth Bader Ginsburg a good example of the role of exercise? Her personal trainer and someone who went through multiple cancers, a coronary stent. Do you think exercise maybe played a role in her unique longevity with all that went on?
Absolutely. And also too, actually, probably her behavior of being an exerciser before. We know that those, for example, in breast cancer, those who exercise before their diagnosis do better. with treatment. I mean, and I see it every day where, you know, patients who were exercisers who even tried to exercise even a little bit, you know, so oftentimes they'll get chemo or treatment every 3 weeks. The first week they may feel very poorly, and even into the second week, but by that third week, right before they get chemo again, they actually feel better. And those who even continue to try to do what they can, end up saying that they feel better, they do better, and long term they do better as well. So yes, exercise is super, super important for all of us. And then also it has benefits long term, when unfortunately we may get diagnoses like these, because the reality is that this is going to be something that all of us are probably either personally or very, you know, close within our network dealing with.
Dr. Reddy, just to give people an idea, in a non-university setting, but still an academic program, how large is your cardio-oncology clinic in Puebla?
So sorry. So we actually, it's not large at all. So, you know, if we do have any patients that, like Dr. Kondapalli mentioned, the main important thing is to have somebody in a tertiary center that can help manage these patients. So most of the patients will be referred in a setting like ours.
If anyone else has questions, you can put it in the chat and we'll pass along. Let me throw one other thing out. Dr. Parr, tell people one of the pharmacologic pearls you've learned through your experience with cardio-oncology.
I would say also, I would kind of echo what Dr. Kondapalli said. The pharmacist has become kind of my best friend in that, and I'm very lucky that I have, you know, a great support team to reach out to when I find that I don't have a lot of experience with a specific drug.
I think Dr. Cleveland has a question or comment.
Yeah, thanks, Dr. Sherman. I was going to ask, and unfortunately being the knuckle dragging surgeon, forgive me, but a simplistic question, but obviously, you know, I've seen the interaction between thrombosis being kind of prevalent in all these things, you know, from the various immune checkpoint inhibitors. So what is the relationship? Do you think it's as much drug? Is it also just the drug cancer as well as the cardiovascular effects, or is that just, I mean, is it hard to tease these out? But I was just struck by the amount of thrombosis that really appears throughout the vascular system. I mean, you can imagine the PAH is some sort of subclinical stuff. So I guess just to throw it out to the panelists to give me a 30,000 view overview of what your thoughts are on this kind of unifying theme.
Absolutely. And also, just honestly, Dr. Cleveland is my go-to cardiothoracic surgeon. So he's very humble because nothing I send him is easy, but he helps all of my patients. So anyway, you know, I think that is the key question. I really think it's inflammation. I know that that's kind of the buzzword in cardiology, but it really has to be. I mean, why are we having these increased, you know, inflammatory events? Like, why is atherosclerosis increased? It just has to be that I think that by targeting, at least in the immune checkpoint, you know, inhibitor story, I think it's this idea that when we target this immune response, we are having downstream effects and maybe perhaps protective effects on the cardiovascular system that also those brakes have been removed. I think that honestly is where some of this is happening. And I think, and then it has to explain also too why the clotting occurs. I will be honest, I think clotting is the major, if we really looked, that is the most common endpoint for so many, and like if we were to look at kind of events, I think that honestly the biggest thing that we would say is not that they have myocarditis or anything, but actually that they have clots, either venous more commonly or arterial.
I'd like to thank I'd like to thank our speaker, Dr. Kondapalli, and our two fellows, presenters and panelists for this. We're right on time, so I'm going to turn it I guess over to Dr. Carter at this point. Thank you all.
Thank you.
Thank you. Great,
Thank you.
great session.
That was fantastic. Thank you, Dr. Sherman. My name is James Carter. Thank you, Dr. Kondapalli, Dr. Parr, Dr. Reddy. Certainly it's been a pleasure working with such a fine group dedicated to put together this first virtual symposium of our Colorado chapter. Special thanks to Dr. Cleveland and to Leanna Collins. We will now transition to the next topics of our foundational science focus that I'm quite excited about: mitochondrial dysfunction and heart failure with preserved ejection fraction, followed by a panel discussion. So feel free to submit your questions and comments. This section is certainly designed to provide us with an enhanced perspective regarding opportunities to help patients with heart failure. I am fortunate to recently get to know our first lecturer, Dr. Brian Stauffer, who was kind enough to pre-record a talk for us. Dr. Stauffer is professor of medicine and chief of the Division of Cardiology at Denver Health, and spends a great deal of time as medical director of Integrative Vascular Biology Lab in CU Boulder and CU Boulder Clinical Translational Research Center. So I hope you enjoy this pre-recorded talk on mitochondrial function, and please send in any questions and comments on the line.
I'm here.
So we're going to flip, if you don't mind, while I figure out how I'm going to find Dr. Stauffer's talk and key it loaded up after yours. So we're going to switch to Dr. Altman's presentation on imaging with patients who have heart failure with preserved ejection fraction. It's very kind of Dr. Altman to provide this presentation to us live. She is an advanced heart failure and transplant expert at the University of Colorado, and in that role developed a heart failure preserved ejection fraction program as part of her clinical and research focus. And because of how this is seeming to become much more of a problem, she now gets referrals from all over the state in this capacity to try to help patients with this difficult problem. So please enjoy this talk on heart failure preserved ejection fraction imaging by Dr. Altman.
Well, thank you, Dr. Carter, for that really lovely introduction. I am getting our PowerPoint up here. Okay. Does that work for everybody?
Good.
Yes, looks great.
Good, great. Okay, so thank you for inviting me to give this talk. I have no conflicts of interest, but I do have an admission that I'm not an advanced cardiac imaging specialist. And so the MRI is not my forte, but I have been working a lot with our imaging folks in developing protocols for HFpEF, so I might have a little to say about it. So what I wanted to talk a little bit about, we've heard a lot about HFpEF overall, and there's been a lot of interest, at least over the last 10 years, about really understanding heart failure with preserved ejection fraction and ways to potentially approach it. Unfortunately, we don't have really great treatment options yet. And so we're still working on truly understanding what HFpEF is and what the manifestations are. And so one of the key parts that I want to focus on is inflammation fibrosis in HFpEF. We know that HFpEF is manifested by impaired diastolic filling, increased left ventricular stiffness, impaired atrial and ventricular conduction of blood, and overall decreased myocyte relaxation. We also know that HFpEF is not solely restricted to what's happening within the heart, but is a complete systemic response to altered altered milieu from the comorbidities. And so we most often see HFpEF in patients with metabolic syndrome, concerns with obesity, type 2 diabetes and hypertension, and renal insufficiency. And so these comorbidities all together start to develop a milieu of systemic inflammation. And so we start to develop elevated CRP and other markers and biomarkers of inflammation that impacts not just the heart, but the lungs, muscular oxygen extraction, and sodium retention in the kidney. And so once all of this starts to happen, that it can start to impact endothelial signaling. And so we have an increase in expression of adhesion molecules, which attacks infiltrating leukocytes, causing fibroblasts to convert to myofibroblasts and increase collagen formation and deposition within the myocardium. In addition, the inflammation results in the presence of reactive oxygen species and reduced nitric oxide bioavailability, which reduces cyclic GMP and then reduces protein kinase G, ultimately leading to hypertrophy and increased stiffness. And so even early on in the HFpEF phase, in the HFpEF progression of disease, we see an increase in pulmonary capillary wedge pressure with exercise and an increase in LVEDP and mean PA pressures with exercise above what we would usually see in normal hearts. Now, as cardiologists, we're used to seeing the classification of diastolic dysfunction based on echocardiographic parameters and this grading level going from normal to grade 1 with abnormal relaxation, grade 2 with pseudonormal relaxation, grade 3/4 with a restrictive pattern, and looking at your E to A ratios and E to E prime ratios. And so I'm not going to go into this in great detail, but basically the underlying reason why we're looking at this is to really determine what's happening with left ventricular relaxation and left ventricular compliance. And so once all of these parameters are taken into accommodation, there is a pretty complex diagram that has been formed for people to really try to determine where patients fit on the abnormal relaxation to restrictive physiology scale, taking mitral inflow into account as well as the E over E prime. And all this is well and good, but what that means prognostically and what that means clinically is still not always clear. And so trying to better understand what's happening within the myocardium is essential. One of the more recent ways of trying to evaluate what's happening within the myocardium, at least with echocardiography, is by using global longitudinal strain. And this is typically through speckle tracking assessments and is usually associated with markers of increased wall stress and fibrosis. We're familiar with using global longitudinal strain in systolic dysfunction, but we've actually seen in a number of either subgroup analyses of the TopCat trial or meta-analyses that there is an increased or abnormal strain rather within patients with HFpEF, and this may lead to even a 2 times increased risk of cardiovascular death or heart failure hospitalization or aborted cardiac arrest within the HFpEF patient cohorts. And so this may be an additional marker of heart failure with preserved ejection fraction and also potential prognosis. So because echocardiography is still a little bit murky and we can diagnose diastolic dysfunction, but that does not necessarily mean, even with the presence of diastolic dysfunction, that patients have heart failure with preserved ejection fraction. We still need to determine clinically what are the parameters by which we're going to define HFpEF. And so what we've moved to doing is a kind of a combined diagnostic parameter utilizing both the presence of a normal ejection fraction or an EF over 50% in combination with the presence of heart failure symptoms. And personally, this is what I'm using when I kind of determine whether a patient has HFpEF, one of these. Either a prior heart failure hospitalization that required IV loop diuretics, elevation in BNP or NT-proBNP, evidence of diastolic dysfunction on echocardiogram, or if patients have normal natriuretic peptide levels, taking them to the cardiac cath lab and actually performing invasive hemodynamics. And if on those hemodynamics, the wedge pressure is over 15 at rest or rises to over 25 millimeters of mercury with exercise, that would give us a diagnosis of HFpEF. So if we're still not sure, are there other non-invasive testing or diagnostic modalities that we might be able to use to help really determine and define HFpEF and determine what prognosis might be? And so I really believe that this rests within the myocardial fibrosis and inflammation picture that we see with HFpEF. So we know that with myocardial fibrosis is an increase in collagen deposition, which leads to increased left ventricular stiffness and reduced chamber compliance. And this can overall lead to either diffuse myocardial fibrosis or complete myocyte replacement with scar. In an autopsy study, it was noted that there was worse fibrosis in patients with HFpEF. And so how does this actually happen? So this is a really nice diagram by Nathan et al. That you can find in Jack in the 2011, in one of the 2011 journals. But basically what this is showing is that it's a complex process of myocardial fibrosis. And the myocardial fibrosis truly involves every cellular component of myocardial tissue. The fibroblast has a central position in this process here by increasing production of collagen and other extracellular matrix components under the influence of different factors, including renin-angiotensin system, myocyte apoptosis, pro-inflammatory cytokines, and reactive oxygen species. And so this deposition of collagen can lead to replacement fibrosis and ultimately scarring at the end stage. And patients with HFpEF can be found at any stage along this continuum. In addition, they've also added the infiltrative interstitial fibrosis that we see in amyloidosis and Fabry syndrome. And this also can lead ultimately to diffuse fibrosis, but is marked by infiltration and deposition of other types of entities, including amyloid protein. And so I thought this was a really beautiful picture that Dr. Lewinter published in Circulation. And this is looking at the extracellular matrix component of cardiac myocytes. And here you can see in the normal cardiomyocyte milieu, there's some collagen deposition, but this is kind of fine. But in HFpEF patients, the cardiac myocytes are markedly hypertrophied, and the collagen deposition is really quite thick and impressive. And when they took cardiac myocytes impacted by HFpEF, the overall stiffness and stress as compared to sarcomere length was markedly increased. And this is even over patients with hypertension alone. So how do we determine what the degree of myocardial fibrosis is, and is this prognostically important? So the best way that we really have to do this from a non-invasive standpoint is using MRI. And MRI, as we already know, is very useful in multiple disease modalities, but we're going to focus on calculating the T1 scores and looking at extracellular volume management. Oh, excuse me, extracellular volume measurement. So in evaluation of non-ischemic cardiac pathologies, evaluation of myocardial scarring and fibrosis has been done using delayed gadolinium enhancement in cardiac MRI. And so there's actually a very nice table here looking at a number of different etiologies of cardiac dysfunction. And the problem with late gadolinium enhancement is it can be nonspecific, and it can be overall not even present in certain etiologies of HFpEF and heart failure. So there's got to be a different way of figuring out how to really visualize HFpEF in these patients. So we know that in non-ischemic dilated cardiomyopathy, LG has prognostic value. We see 3 times increase in heart failure hospitalizations and cardiac death, increase in sudden cardiac death in these patients who have evidence of late gadolinium enhancement. In hypertrophic cardiomyopathy, presence of LG has an increased risk of arrhythmia and sudden cardiac death. And also in cardiac amyloidosis, there's an increased risk of cardiac events with the presence of LGE. But LGE is good for determining overall the myocardial replacement fibrosis and scarring, but in the picture of diffuse interstitial fibrosis, it's less helpful. So more recently, we've been turning to newer modalities, including T1 relaxation times. And this is really a method of tissue characterization with MRI. So T1 relaxation times are determined by the longitudinal spin lattice relaxation time. And honestly, this is a little bit beyond my overall understanding of the mechanics that work with MR. But basically, there have been some really great technological improvements in T1 mapping, and allows for really high spatial resolution using the 1.5 Tesla scanners, and patients only need to do a single breath hold. And what's happened is that it's been able to remove variation in signal intensity and signal enhancement, and allows for a better understanding of the degree of fibrosis within the myocardium. There are multiple sequences that have been used, not all have been validated, and not all have been compared to endomyocardial histologic samples either. But it does allow for a quantitative assessment of diffuse cardiac fibrosis, which is a new way for us to look at this, and does allow us to estimate the extracellular matrix volume. T1 mapping and extracellular volume estimation has been correlated in some studies against histology in hypertrophic cardiomyopathy and amyloid, and it does really seem to correlate with myocardial collagen content. However, when we're looking at T1 mapping, it's important to note that the volume of extracellular matrix can be increased in both myocardial fibrosis and with inflammation and edema. And so in patients with disease states with less severe fibrosis, it may be a little less sensitive. However, it's one of the better tools that we have currently. And so this is looking at a study of 100 patients with diagnosed HFpEF. And in those patients with a T1 time less than the median, there was a much lower proportion of time free from cardiac events and death. And so prognostically, it does seem to be important. In addition, in this study, they took 9 consecutive patients with HFpEF, and after CMRI, they underwent left and right heart catheterization and left ventricular biopsies. And so these here are parallel sections from representative myocardial biopsies of patients here in panel A and B with confirmed HFpEF, and panel C and D with normal cardiac function, and in panels E and F with cardiac amyloid. Panels A, C, and E have been subjected to trichrome staining, which helps to really light up the fibrosis here. And so you can see all of this purple stuff in panel A shows this myocardial fibrosis, which does look somewhat diffuse. C, there's really no purple staining, and E, in the amyloid patient, there's really a lot of diffuse fibrosis. And then panels D, B, D, and F have been subjected to Congo red staining specifically to look for amyloid. And here you can see the amyloid fibrils and amyloid deposition with the arrows in F. So what we have been able to determine from these patients is that the relative amount of extracellular matrix correlated with post-contrast relaxation time in these 9 patients who underwent endomyocardial biopsy. However, the T1 time was not related to the amount of collagen that was found. It was really that the total amount of extracellular matrix with the multiple components thereof was more of a common denominator that seemed to drive prognosis in HFpEF. So what about this extracellular volume? What's going on in the extracellular matrix? Now, in patients with kind of a variety of etiologies of cardiac dysfunction, we know that patients with cardiac amyloidosis and myocardial infarction who have focal fibrosis have a much higher proportion of myocardial extracellular volume than patients with dilated cardiomyopathies and HOCM or hypertrophic cardiomyopathies. And so the extracellular volume expansion really is occurring with an increase in water and collagen deposition or with some kind of infiltrative myopathy. We can add extracellular volume measurements to traditional MRI scans by measuring the T1 weighting before and after contrast equilibrium and directly measuring the blood volume of contrast distribution using a hemoglobin level. And so here is images of MRI scanning in patients with hypertrophic cardiomyopathy, dilated, and HFpEF, looking at late gadolinium enhancement, native T1, and then extracellular volume measurements. And you can see here that the late gadolinium enhancement is really not there in any of these disease modalities. But the native T1, or the presence of fibrosis, is here and significantly raised throughout patients with HFpEF. In addition, the extracellular volume here in the blue is really much higher in patients with HFpEF, and here you can see some in the hypertrophic cardiomyopathy patients. We also know that the increase in extracellular volume correlates with myocardial stiffness, here with the stiffness constant on the y-axis and the extracellular volume fraction on the x-axis. And then finally, when looking at hemodynamic profiles of these patients, we know that any elevation in extracellular volume can cause an increase in the end diastolic pressure volume relationship. And so this is a study looking at patients with HFpEF, and these patients underwent cardiac MRI and then also invasive hemodynamic assessments with pressure volume loop measurements as well. And so what we're looking at here is this end diastolic pressure volume relationship on the red curve. And the patients with extracellular volume that was greater than the median, so the highest amount of extracellular volume, really had this very, very steep curve, early steep curve, indicating myocardial stiffness. And this here is a representation of the extracellular volume determination. And you can see all of this green deposition is this patchy increase in extracellular volume. There are also a couple of new emerging MRI techniques, including MR elastography that maps shear stiffness of soft tissue. There's also some new experimental 4D flow assessments that patients that are being looked at, and looks at the unfolding of blood flow patterns in multiple dimensions over time, and is really allowing us to see flow differences that we can't see with conventional hemodynamic assessments. So these are kind of exciting modalities coming down the pike. So overall, cardiac MRI does represent an additional and developing modality for assessment of HFpEF severity and prognosis. And in cases where HFpEF is not clear or the etiology is not clear and we do go to cardiac MR, T1 mapping may be considered as an additional biomarker in the evaluation of HFpEF. Thank you.
Fantastic. Excellent, excellent presentation. I appreciate the you giving us the context prior to getting into the imaging discussion. It was quite good. We're going to try to load Dr. Stauffer's presentation again. Let's see if we can get that running. Talk about with Dr. Altman's presentation as it is. And we can also invite Dr. Larry Allen, if he is on the call, to participate. Is Dr. Allen with us also?
I'll shoot him a quick text, see if he's around.
Okay. Well, I think we can start a discussion, Natasha, if that's okay.
Sure.
I'm intrigued by this topic because it seems to me that we are seeing more and more of these patients. And clearly by your expertise and your experience, you may be seeing that as well. I'm wondering if you're seeing any differences between rural communities and urban communities, whether there are any types of patients that are more vulnerable to this presentation, if you can share any insight into that.
Sure. You know, I think heart failure overall and the evaluation of heart failure overall is certainly limited by who is presenting and how early we're catching patients in their course. I think socioeconomically, often we'll find patients in a later course with fewer resources, in the more in patients who are living in more of a poverty type of situation. You know, I think I've may have a more skewed version of the population being at a quaternary medical center. And so I'm being sent patients who are already being seen by cardiologists. But I think, you know, determining what the next steps are in terms of outreach and who to focus on with education is really important. You know, in terms of kind of a common pathway of developing HFpEF, we know that patients who are older have hypertension, have diabetes, have metabolic syndrome, are really at higher risk for developing HFpEF. And so in the patient populations who have less access to good medical care, focusing on primary prevention of HFpEF in just a lifestyle manner is really important.
Yeah, certainly there seems to be an overlap between, and we've heard it from Dr. Kandapali and others even this morning, between the immune system and these inflammatory markers. You talked about this fibrosis that occurs in the interstitium of the heart. And we also are concerned about oxidative stress. And you mentioned some of the things that can lead to that. I'm wondering about some environmental things. We're in this period of a great deal of air pollution, and we get these warnings every day. Do you expect to see any type of uptick over the next several months or years, or is there no association?
I think it's very hard to say. HFpEF is such a multifactorial disease with so many different phenotypes. You know, if we think about reactive oxygen species alone and the fact that increase in reactive oxygen species may lead to inflammation and ultimately fibrosis, certainly I would expect to see that happening on a systemic level as well with both cardiac and pulmonary sequelae as well. But I think it's hard to say. I think you have to have an overall milieu as well of comorbidities to really see HFpEF. I'm not sure that air pollution alone would cause it, but it's possible. Yeah.
Joining our panel is Dr. Larry Allen. Dr. Allen is professor of medicine and associate head of clinical affairs and cardiology at University of Colorado and medical director of advanced heart failure, author of many publications on heart failure and clinical decision-making approaches, some of which we touched on today with Dr. Altman's talk. Dr. Allen, we're in the middle of a conversation. We are a little off schedule because of some video issues, but we had a fascinating presentations on cardio-oncology, and then Dr. Altman shared her perspective on mitochondrial dysfunction, on heart failure, preserved ejection fraction, and imaging. And we are starting to entertain questions about this, understanding that this scope has become broader and broader, and we're seeing more and more of these challenging patients. We have a question, Dr. Altman and Dr. Allen, if either of you can comment on SGLT2 inhibitors and their potential use and benefit in patients with heart failure and preserved ejection fraction with and without diabetes.
Yeah, I can take that, Natasha, and you can fill in. You know, in the last essentially 12 months, been two large trials in reduced ejection fraction. The first was DAPA-HF, nearly 5,000 patients, half of them with diabetes, half of them without, and impressive benefits over 18 months with dapagliflozin in those patients. The benefit was irrespective of their diabetes status, and a number of thoughts about why that would be the case that we can get into. And then just 2 days ago or 3 days ago, the Emperor Reduced study was published, which showed essentially identical findings to DAPA-HF, again in reduced ejection fraction patients, where empagliflozin, also 10 milligrams daily, made a huge difference on top of other guideline-directed medical therapies. I think that there's a lot of excitement that SGLT2 inhibitors may finally be a drug that helps out in HFpEF, in part because when you look at EMPA-REG, CANVAS, and DECLARE studies, the endpoints in those studies, the combined endpoints, were largely driven by decreases in new incident heart failure, of which much of that was HFpEF, although those studies didn't collect detailed echo data. And in the DECLARE study in particular, 11% of people actually had heart failure when they were enrolled in the study. Many of those were HFpEF, and they seem to have less events. So I think people are excited about SGLT2 inhibitors for HFpEF based on the impressive findings in HFrEF, as well as the findings in diabetics. Unfortunately, there has been one smaller randomized trial of HFpEF, and it did not show significant benefit. So, you know, I think the verdict's still out on whether SGLT2 inhibitors will help HFpEF patients, particularly HFpEF patients without diabetes. The Emperor Preserve study is to be published in the near future, and there's actually about 3 large studies in HFpEF that will be coming out in the next 2 years. So we will have an answer, but what I would say is if you have a patient who has reduced ejection fraction, I think SGLT2 inhibitors are now essentially first-line therapy with beta blocker, ARNI, and mineralocorticoid receptor antagonists. If you have a patient who has type 2 diabetes and either has heart failure or is at risk for heart failure, I would say SGLT2 inhibitors on top of metformin are strongly recommended. And if you have a HFpEF patient who does not have diabetes, we do not know whether that's helpful. And it's likely that that patient is going to pay a lot of money out of pocket for that drug. So I am not prescribing SGLT2 inhibitors for HFpEF patients without diabetes currently.
Excellent. We have a question from one of the audience members. How often do you think MR will replace transthoracic echo for diagnosis of HFpEF?
I think MR is going to be one modality that will be helpful for evaluation of HFpEF. I think it's an expensive modality. A lot of patients can't tolerate it due to claustrophobia. And so I think echo will remain our first line evaluation modality for HFpEF. I usually will go to MRI if clinically I'm feeling that either there may be some other etiology underlying, I'm looking for amyloid, I'm looking for cardiac inflammation, or if I'm really concerned that the patient's severely impaired but not quite sure prognostically how this might impact them. So I wouldn't say that MR would be first line, but I think it's a really great tool in our arsenal for understanding the severity of HFpEF and how to prognosticate for these patients.
One last follow-up question. How do many of the heart failure preserved ejection fraction patients actually have some form of amyloidosis? That's a question from a participant.
Yeah, that's a great question. And I think, you know, the amyloid picture is evolving. I think it's really interesting. We know that TTR amyloid in particular and the senile wild type amyloid is far more prevalent than previously understood. Also now with the treatment option for TTR amyloid with tafamidis, I think we're more aggressive about evaluating patients for amyloid because there is a treatment modality. It's interesting though that when this drug came out, it was pigeonholed into a rare diseases type of drug treatment, but I really think that the prevalence of TTR amyloid in particular, and the wild type in particular, is far higher than we recognize. There have been some autopsy studies of patients with HFpEF that showed even up to a 20% proportion of patients with amyloid, but I'm not sure how much this was skewed by the severity of HFpEF. But what I would say is in any patient who's presenting with HFpEF, I usually do a baseline screen to evaluate for some form of amyloid. And in these patients, in addition to BNP, I will sometimes check a troponin because elevations in troponin and BNP are typically found in patients with infiltrative disease. And then I will check SPEP and UPEP to evaluate for an AL amyloid component. If the SPEP and UPEP are negative and I still have a high index of suspicion that a patient has amyloid, I will typically move to ordering a technetium PYP scan to evaluate for TTR amyloid. And this is also where MRI comes in. So if I'm not sure and don't want to go directly to endomyocardial biopsy, and the SPAP, UPAP light chain analysis is kind of equivocal, I might go to cardiac MR to evaluate for infiltrative disease.
Fantastic. So let's thank you so much. Let's move on and see if we can load up Dr. Stauffer's presentation.
First, I'd like to thank Dr. Carter and the Colorado ACC for allowing me to share on mitochondria and the failing heart. I'm going to talk a little bit about mitochondria, how they work, what they do in the heart, how they change with heart failure, and then talk a little bit about some of the novel therapeutics that are on the horizon and some of the work that we've done investigating at least one of these.
Hey, James, while we're still working, can I ask a question of Drs. Allen and Altman as well?
Yes, please.
Yeah, so it was a fantastic talk, Natasha, really enlightening. And I guess, thinking about next steps, the imaging is fantastic. You pointed out the limitations of gadolinium, et cetera. In your world, you place devices, CardioMEMS, for monitoring people. Larry's world, send people for endomyocardial biopsies. Is anybody biopsying these myocardium, doing like with a right heart biopsy? Understanding it's a little harder to get left-sided biopsies, but to look at tissue, correlate it with any of the imaging things, and trying to see. You showed some nice histology slides that I guess could have come post-mortem, but I guess just a tissue type based exploration of this. Is that, where do we stand with that?
Yeah, so there have been some smaller studies that have looked at histology and overall trichrome staining to determine the degree of fibrosis in these patients. One limitation is really that, are we here?
No, you can keep going.
Okay. One limitation is that we don't necessarily understand, if we don't see a large degree of fibrosis, what else might be happening within the real extracellular space and also within the myofibrils. There was a recent publication from Johns Hopkins looking at histologic evaluation of patients and including kind of a multimodality phenotyping. And so this is becoming more of a research focus. Tim McKinsey in our basic science labs has been looking at the extracellular volume, extracellular matrix, stiffness within the matrix, and also looking at myocyte relaxation. And he has set up to really evaluate that. And so in the future, we're hoping to do some biopsy-based evaluation of these patients, and potentially even trying to develop some kind
I'd like to thank Dr. Carter and the
intervention as
ACC
well.
for allowing me to share.
But yeah, the research is just
mitochondria
coming out on
and
these
the
patients, and
failing
I think
I'm
the
going to talk a little bit
multimodality
about,
phenotyping
mitochondria, how they
is going to
work,
be important for us to
what they
understand
do
what's
in the
going on.
heart, how they change with heart failure, and then talk a little bit
Okay,
about
we're ready to roll with Dr.
some of the
Stauffer's
novel therapeutics that are
presentation.
on the horizon, some of
After
the
his
work that we've done,
presentation, we'll take a short
investigating at least
break.
one of these.
Pay particular attention to the basic science part of this presentation, and then the exciting new things to look forward to in the
So
future.
mitochondria are an important organelle in the heart. The heart possesses the highest content of mitochondria of any tissue, and it's up to 30% of total cell volume. This in myocytes, cardiomyocytes, is second only to the myofilament. Mitochondria are dynamic organelles with really robust quality control measures. Fission, fusion, change mitochondrial form and number, and autophagy provides control for programmed cell death and other global cellular processes. When we think of mitochondria, we have to think about energy balance in the heart. So it is very important because the human heart consumes almost human body weight of ATP per day, and this must all be generated dynamically. The ATP concentration in the heart at any one time is actually quite low, 10 millimolar, but the energy demand is high, and so the existing ATP concentration is only sufficient for about 10 seconds of work. Usually energy demand is supplied through fatty acid oxidation in the mitochondria. This is a primary pathway for ATP synthesis and 20 times faster than glycolysis. When we think about the energy balance, we think about the supply part, which I just discussed. Oxidative phosphorylation is the predominant portion of this in the mitochondria, and then there's some glycolysis that occurs. And that is necessary to keep up with the demand. So ion channels and pumps, heart rate is a big component of energy demand, and then relaxation and contraction both take energy to perform. And these are the portions of heart failure that we worry about as well with HFpEF and HFrEF. It's known that ATP is the primary energy source, and phosphocreatine is the energy reserve compound in the heart. And there is some very elegant work that was done back in the 90s with SPECT, NMR SPECT, looking at these high energy phosphates and what happens in the failing heart. Under normal conditions, you can see that there is a fairly robust phosphocreatine peak as well as a fairly robust amount of ATP present. But as you progress through various stages of heart failure, the phosphocreatine peak diminishes, and the ATP peak also diminishes, although that's a little bit less obvious here. So there is a progressive loss of ATP that is about a 30% decrease in the failing heart. And creatine concentrations decrease by a half to 2/3. And this enters the cell through an active process. So this is not something that is produced and used and reproduced. This is something that has to be transported in. Energy depletion has been demonstrated in both HFpEF and HFrEF hearts in several studies. So in the setting of these changes in ATP and phosphocreatine, we know that energy balance changes in the failing heart. There's activation of the sympathetic nervous system, which produces excess reactive oxygen species. Energy metabolism remodels. And there's a switch from the fatty acid oxidation to more glycolytic pathways. This is 30% more efficient, but it is not as robust overall. These changes in supply are worsened by increases in the demand side with changes in relaxation and contraction, needing just as much or perhaps more energy. Current medical therapy is focused on decreasing the demand. So beta blockers, ACE inhibitors decrease energy demand, and so really act on this side of the balance. There really remains an opportunity for us to address the energy supply part of this equation, and a number of these things, the elevated ROS, the decreased mitochondrial capacity, changes in electron transport chain and membrane fluidity, are all targets for novel therapies. So how does the mitochondrion work? Just a quick refresher. So the electron transport chain, which is this series of complexes, is embedded in the inner mitochondrial membrane in a lipid bilayer. And these complexes have multiple proteins as a part of them, and depending on the input, generate electrons that cycle down through and create this proton gradient between in the intermembrane space. These protons then move through complex 5, and that's what generates the ATP. So complexes 1, 3, and 4 are part of what's called the supercomplex. And these are very tightly coupled under normal circumstances and transmembrane proteins. Complex 2 is embedded in the membrane, but it is not a part of the supercomplex. It's one of the complexes that can very easily be dissociated. And so when we look at mitochondrial function, we can look at, is it the supercomplex? Does it involve complex 2? And then coenzyme Q has also been shown to change in heart failure, and cytochrome C is important for cellular homeostasis as well. And these are tagged into the electron transport chain. So the membrane plays an important role in electron transport chain function. It's complex with a number of different phospholipids, but importantly, it has this unique phospholipid called cardiolipin, which is here depicted in the blue and down in this figure. Cardiolipin is a unique phospholipid with 4 fatty acid side chains. And under normal conditions in the heart, these are all cis-linoleic acid. And we'll talk a little bit about changes that happen in cardiolipin, which lead to changes in the membrane. So with heart failure, we do know that there are modifications of mitochondria. There are changes in the amount of the electron transport chain complexes, specifically complex 1 and 4. And as I mentioned, coenzyme Q also is decreased. There are abnormalities in cardiolipin or in the membrane. And that's depicted in these figures with, this is what we think a normal mitochondria looks like, with the electron transport chain at the end of one of these cristae, and surrounded by cardiolipin, which is what gives it this curve and allows the complexes to be tightly coupled and pass electrons down without releasing a lot of reactive oxygen species. In contrast, cardiolipin is reduced and modified, as I had mentioned before. Normally it has 4 linoleic acids as its side chains, and with heart failure you can get substitutions of other things, oleic, arachidonic, and that changes the conformation, spaces out the complexes, increases electron leak and reactive oxygen species. Altogether, this produces a decrease in cardiac efficiency and contributes to the myocardial dysfunction. As I mentioned before, most of our therapies are on the demand side of the equation, but there have been a number of recent efforts to try to address the supply side. And one of the ways to do that is by increasing the number of mitochondria, so increased mitochondrial biogenesis. I think resveratrol is one of the most commonly used in this category. There are strategies to replete coenzyme Q, which is decreased in heart failure. MitoQ is a mito-targeted coenzyme Q. Ubiquinol is a reduced form. Idebenone is also another compound that's been in clinical trials. There have been studies to try to address the excess reactive oxygen species. We know that antioxidant therapy in states of low oxidative stress are really helpful. And there hasn't been a lot of good evidence for this strategy in heart failure due to some study limitations. But there are several novel compounds, XJB out of Pittsburgh, Mitotempo, that are designed to address the excess ROS. Now, reactive oxygen species is kind of an interesting concept, because if you have too much or too little, it's bad. You have to have just the right amount, because there are some signaling aspects to this process as well. And then cardiolipin targeting. And this is all based on a compound that was born as SS31. Then it has been developed through a startup company into elamipretide that has been studied in preclinical and a number of clinical models. And this is the compound that we have studied as well. So we partnered with this biotech company that develops elamipretide. It's a cell-permeable pentapeptide. It shows biological activity in isolated mitochondria and happens very quickly in vitro. Efficacy is generally seen when there's mitochondrial dysfunction present, but in the normal mitochondria, it doesn't really appear to generate any changes. A couple labs early on especially showed that there was a reduction in ROS production, and so initially this was thought that maybe this was a scavenging molecule, but more recent investigation into this does not bear that out. And it displays activity on several different complexes, primarily those in the supercomplex. And it's thought that it does this through an affinity for cardiolipin, which then allows the electron transport chain to more closely couple and decrease ROS and increase energy generation. Before we started working on this study, there was no data specifically in the human heart. There were a number of clinical trials that were looking at whole organ function, but we hypothesized that we could treat isolated human heart sections with elamipretide and get some objective evidence that there was a benefit in mitochondrial function. So the way we did this, I think a lot of people know that the University of Colorado has a pretty large tissue bank, and we have tissue collection services that get the hearts out of the OR at both Children's and UC Health. All of these studies have to be done in freshly isolated tissues, which creates somewhat of a challenge. So we have 24/7 collection and do the experiments at the time of collection. And this is ages from birth to 68. I'm going to separate some of this out based on pediatric and adult. And we have all sorts of diagnoses, but the data that I'm going to show you today is all in dilated cardiomyopathies. So what we did was take these freshly explanted hearts. We put them in this machine that is a closed sealed chamber. And we can measure how much oxygen is used. And this is really the best functional assessment of the intact mitochondria, because we can see it without any membrane fracture. You can see the supercomplex in action rather than the individual complexes. And all samples were assessed in a pairwise fashion, so we treated one part of the sample without the compound and the other part with the compound. This is what our data looks like. So this is a very powerful technique. It allows us to put the tissue in this chamber, and then we can add substrates to increase energy generation, oxygen consumption, or decrease it, depending on what you're looking at within the electron transport chain. And on these graphs, this is the same axis here. You can see that the non-failing generates a lot more energy, uses a lot more oxygen, which is directly proportional, than the failing one, which is these red lines. In a little bit more straightforward fashion, we can look at what each of the components of the electron transport chain do. So we add the different substrates and can see these two substrates directly feed into complex 1, and we've seen that in the white, the non-failing produces a normal amount of oxygen flux, and then in both pediatric and adult dilated cardiomyopathies, we see a decrement in mitochondrial function at complex 1, but when we add the substrate for complex 2, feeding electrons in through a different mechanism, the function is not significantly impaired, suggesting that most of the impairment here is in complex 1 and not in complex 2. So all that was to just demonstrate that in our hands, we've been able to reproduce the the impairment that others have seen. When we did our pairwise comparison, this is a failing sample. The top is vehicle treated, so untreated with the drug, and below is treated with the drug. And again, on the same scale, you can see that the oxygen consumption is much greater in the failing sample treated with the compound, suggesting an improvement in mitochondrial function. Looking at these individual steps rather than across the entire curve again. So the blue and the red are the non-failing, untreated, and treated, respectively. And you can see we've reproduced this failing decrement. So these are both pediatric and adult samples. And they improve when we add the drug and do the mitochondrial function in the setting of the drug. Again, this improvement is not as great when we add the substrates for complex 2 on top of the complex 1 substrate, suggesting that most of this impairment is in the complex 1 of the electron transport chain. So that's all well and good. We like it that we can improve mitochondrial function. We've done some other studies that suggest that there is a decrease in ROS. And so mitigation of ROS is one thing. There are a number of other post-translational modifications of proteins that we've been able to observe. But one of the real questions is, does this have any impact on function? And so one of our junior faculty, Casey Wolf, who did her PhD with Tom Force and came out in postdoc and stayed on as junior faculty in our division, has the ability to look at isolated sarcomeres. So you tease apart the muscle, just get the contractile elements, and can measure maximum tension. So what she did was measured maximum tension in the control, so the untreated samples and those treated with L-mepritide. She normalized each one, since it's a pairwise comparison, to 1, and you can see the increase in each of these samples when they're treated with the L-mepritide. So we think that this is pretty cool data, suggesting that even in the absence of mitochondria, so this is mitochondrial stripped away here, they were treated with the drug, and then this has all the substrates that one needs to contract. Is not relying on mitochondria itself, but there's some lasting change here that happens that improves the contractility of these hearts, which we think is great. So in conclusion, we know that mitochondrial function is impaired in the failing human heart. We've demonstrated that in both adult and pediatric samples. There are a number of emerging therapies that are targeted to improve mitochondrial function. We studied L-mepritide, and L-mepritide can improve mitochondrial function in the human heart. We also have very preliminary data that this may also improve contractile function. We think taken together, these data suggest that there may be a utility in adding some of these targeted therapies to standard medical regimens. I'd like to acknowledge the people that do this work in the lab, and thank you for your attention.
Dr. Williams?
Well, hello. Thanks for the introduction, and it's certainly my pleasure to be here again at the Colorado ACC. Unfortunately, I'm actually in my living room, of course, as we were doing things in a very different way. And I want to talk today about the topic of COVID-19, but in the context of cardiology and the social determinants of health. I'm really pleased to have an opportunity to present this, and saddened by the fact that one actually has to discuss such things. And so if we take a look at What I'm going to try to do today is talk a little bit about the background and the history of the healthcare disparities, some of the issues, including access to care, some of the potential solutions, which include identifying people who are at risk, and one of the vexing issues of our regulatory system, just one of them, there are many, but I'm going to call one out, and that's the readmission penalties. And then lastly, I'm going to spend probably the last 1/3 of the time talking about the innovation that I think we need to make this better. In terms of the background and history, everybody knows that 1 out of 3 deaths in the United States are due to cardiovascular disease, someone dying every 37 to 40 seconds. But that bottom bullet, that nearly half of African Americans have some form of cardiovascular disease, is not very well known. We also have had a tremendous improvement in cardiology for all of the things that you guys and ladies and APPs and everyone who's an ACC member, who've been in the middle of this for so long, decreasing cardiovascular mortality. And so this slide is wonderful. It depicts a lot of the therapies and how we've improved many aspects of cardiovascular care to lower mortality, about 70% over the last 4 decades. What it doesn't show, being published in 2012, was that there was going to be a plateau and that it was going to be on the rise again. A lot of that has been attributed, and I think partially true, at least, that what we were doing with defibrillators and stents and bypass surgery is that we were mopping up the floor and never turning off the faucet. And so we were going to pay the price at some point that we were going to reach the limits of our ability to decrease cardiovascular mortality simply because we weren't changing the fundamental dynamics. We were just treating what was presenting to us. Now, if we look at the US population, we have to be concerned about minority health. And that's really because it's going to become a larger and larger population of the portion of the population as time goes on in the United States. And one of our most difficult areas, as I mentioned, is the fact that African Americans have more cardiovascular disease and more mortality. The heart disease and stroke issue was called out by Clyde Yancey and his group, and it's loads of publications, and it boils down to several things. If we could actually lower the traditional cardiovascular risk factors in the African American community, hypertension, diabetes, obesity, atherosclerotic cardiovascular disease, we would actually be able to impact the disparities in stroke, heart failure, peripheral artery disease, myocardial infarction, and death. So let's focus on those things. And just, I know you're very familiar with it, but it's going to come up over and over again during my talk. Stepping back for a moment away from cardiovascular disease, we have to understand that there are socioeconomic, cultural, and environmental conditions that have been beset upon the cardiovascular health of the inner cities and minorities and people who are in underserved populations. That has to do with a lot of issues of like undereducation, the food system, the work environments that people are in, and all of this has been amplified by the COVID-19. And we can see that the people who are front-facing and don't have the ability to isolate themselves, and for financial reasons, just making a livelihood, putting themselves at risk, resulting in a higher mortality rate. Now, if we look at the life expectancy differentials, and it's worth doing because the majority of this really is cardiovascular, the life expectancy is substantially less. And there have been, if you look at that bottom graph on the left, the African American males, sure, there's been a substantial improvement over time, but it's still not to where it should be. And the gap between whites and blacks, and which is really profound, is there for women, but it's even more so for men. It remains. Now, a lot of that is economic. And so if you just stare at this for a moment, you'll be struck by the fact that there is a relationship between income in a county and the mortality rate. And so the poorer you are, the more you die in this country. And this isn't really what we aspire to, but these are data that we can't run away from. There are some factors that increase mortality that are controllable and some that are not. The premature mortality of smoking, obesity, having structural racism and greater inequalities, poorer education are there. And we assume that African-American races, but in many situations, as I'll describe later, once you control for all the variables, maybe African-American race isn't so bad, but maybe it's actually all of the environmental factors that surround. On the other hand, there are factors that reduce mortality, and one of them is education, and another one is just being Hispanic. How you can have a population that has a lot of obesity, particularly central obesity, has a lot of hypertriglyceridemia, specifically having a lot of coronary disease and longer life expectancy, despite a large burden of disease. A lot of that has to do with social structure, but it's very clear that there are differences among our populations. Now, we're not saying that that's a great thing. To have a short, sick life with being African American is not good. Having a long, sick life being Hispanic is not good either. And so we really do need to do the kinds of things that can impact the risk factors in both populations. How about access to care? So this is one of the more startling features of our system, and it underpins the issues of mortality. If you look at potentially avoidable hospitalizations, just simple things that take your blood pressure so you don't end up with a stroke or accelerated hypertension or heart failure or renal failure on dialysis, what you see is a large amount of both Black and Hispanic compared to other populations. And so this is something that we have to recognize, and we have to try to invert this. And the way to do it, of course, is to spend more time healthcare, and we'll talk about screening methodologies. Well, just it has to be addressed by focusing our healthcare efforts on those communities that need it the most. We still have procedure and referral disparities. I hate to say they're true in cardiology. The middle paragraph about having less catheterization, less bypass surgery advice, not revascularized, and when appropriate use is examined, less pacemaker placement, ICD placement. These are things that hopefully we are going to see improve gradually over time as the society as a whole is dealing with the structural racism, particularly with all of the differences that have been pointed out during COVID and the Black Lives Matter movement with everything that's happened this summer. And so we expect that over time, if we really focus our efforts, you're going to see much better primary care. It's something that really can be done, just a matter of application of our resources in the communities where people need it the most. Because right now there are large gaps between the ability of different races to actually see primary care, and it's very true of specialists as well. This is a very famous article, but it's getting a little old, which means that it's time to talk about it again, because folks did not necessarily hear that New England Journal of Medicine article that talks specifically about actors of different gender, age, and ethnicity being giving the same story to a group of physicians at the American Academy of Family Practice and the American College of Physicians. So these are our primary care colleagues. And what they found was very startling, that given the same symptoms, including, describing angina pectoris that was severe, including a positive Levine sign, the odds of getting a catheterization or referred for further testing was about 40% less if you were a woman, about 40% less if you were Black. And so, of course, the worst would have been an African-American female with about 60% less. And so that really does, you know, make it really important to try and fix some of the disparities that we have in the healthcare population, particularly in cardiology, as you know, because ACC has been working on diversity and inclusion for about 4 years now. It turns out that cardiology is less diverse than the US population. Less than 10% of medical schools, medical students, and only and less than 3% of medical school faculty are actually African American. And we suffer in terms of number of trainees, and in both the African American and Hispanics. And we are trying to make sure that this is known. We're working as a committee to try to increase these numbers substantially. And it'll take a lot of time and a lot of effort, but we'll try to get there. It's not just the population, it's also cardiology is less diverse than medicine. And so that is more of a gap in women than it is in African Americans or Hispanics, but these are the things that need to be right-sized. We need to take a look, as we are with our diversity, equity, and inclusion group, to try and right-size the number of women, the number of minorities, underrepresented minorities in medicine. The case for diversity in medicine has been made multiple times that we're able to better promote health equity. The patients do, unfortunately, particularly in the underserved community, they respond to the physician who looks like them. And that is something that, you know, maybe a generation or two from now, that won't be the case, and we can all be one, but right now we need to focus on trying to increase our diversity to serve our population. How about early screening? So if you look at the prevalence of classical risk factors in our populations, what we actually see is that there are differences in men versus women. The number of obese patients is going up substantially. Hypertension is more prevalent, as you can see, in the Black population. And these are risk factors, particularly like diabetes in the Hispanic population. We actually can try to detect this early and try to do something about it. Being able to actually get therapy, as you see on the right, doing exercise instead of being physically inactive, having control of both lipids and hypertension, we really are struggling, sometimes like a third world country in our minority populations. So we've got a long way to go. It's really great to have an ASCVD risk calculator that now includes African Americans. Obviously, we need it for the Hispanic population as they get larger. And a pool cohort equation would have to be updated with Hispanics once we have large Hispanic pools. One of the things that we're doing at Rush is going out into the community. That's one of the things that Rush University is good at, taking our medical school and nursing schools and PA schools, students and cardiology fellows and everyone who will sign up. And we go into communities, centers and churches. We've been at Veggie Fest a couple of times. We talk about Life Simple 7 message from the pulpit if they let us. And we partner with an education program from the prevention department called Alive, where they actually give like 6 weeks of informative lifestyle modification advice. We call it Helping Everyone Assess Risk Today, and that would be called HEART. And we hopefully will continue to do these early screenings. How about readmission penalties? I want to talk about that because there is a disparity that every hospital that takes care of inner city African Americans and poor people end up with these readmission penalties. It's something that we thought we were going to have it addressed. We talked about it on Capitol Hill. We had people who were very interested in doing this. The problem is that we lost that momentum, and it seems that we may not get that back, but I'm hoping that attention can be paid. So the last portion of the talk, I'm going to talk about prevention, and it's really important to understand that we are in the middle of an epidemic, and that epidemic is similar to what happened in 1918, the last time that heart disease wasn't the leading killer of Americans, and we have to address it. Now, one of the issues with the current pandemic is the underlying illnesses of people who do poorly. Remember that list I was giving you before for heart disease and African Americans? This is a very similar list. We have diabetes, we have obesity, and that increases the amount of mortality in both the Latinx and the Black population because we have so much of these risk factors. So African Americans are 2.4 times whites, or times the rate of mortality in whites. And this is something that we have to address. We have more cardiovascular disease, more obesity, diabetes, hypertension, and hyperlipidemia. And so what I'm proposing is that the answer is prevention, and the answer is nutrition. So we've been talking about this widely. Everyone talks about how more Blacks die, but take a look. If this is published in New England Journal of Medicine, we have data submitted for review from Rush that's very similar, saying that if you look at hospitalizations, sure, it's higher in Blacks versus whites, but if you correct the model for risk factors such as obesity, you end up with that Black is a hair protected with maybe a 0.89, 11% decrease if you're Black, if you account for all of the other issues. And so we really have to face the fact that a Black race is not associated with higher in-hospital mortality, is that they have more risk factors. And if we have more risk factors, we're going to die more. It's not the Black, it's not the race, it's the risk. And so that whole thing about having more cardiovascular disease, it is the risk, not the race. And so I have to mention that we're globally fighting a pandemic. The nutrition issues that we're talking about affect millions of people around the world. And here at home, we have that gap. Yes, we have had a 70% decrease in mortality overall in the United States over 4 decades, but the Black population lags behind. And so this growing epidemic, just want to mention obesity, the hypertension, hyperlipidemia, diabetes, has been making an inroad into the younger population. Pointed out in our Wall Street Journal, of course, they rightly so picked an African-American family who lost the dad to talk about this issue. So what can we do about these 4 risk factors? We actually have good data from the American Heart Association, American College of Cardiology, from our 2019 prevention guidelines, where if we actually do follow those guidelines, lower the blood pressure, lower the cholesterol, get rid of the diabetes, all with the diet, we are actually going to impact not just cardiovascular death, but COVID-19 mortality as well. Our obesity epidemic is very clearly related to related to the COVID mortality. We see risk factors like 3.68 if you have a body mass index greater than 25 for mortality if you get COVID-19 infection. What's wrong with the obese patients? Poor immune system, more cytokines, particularly adipose tissue related adipokines, and their dendritic cells can't mature and make a good T cell response to a viral infection. And so this is something that we need to work on. We need to get rid of the refined grains, red meat, unhealthy fats, and sugary drinks, and eat more fruits and vegetables, whole grains, and nuts. If you look at the obesity issue, it is ethnic as well. If you look at, this is the whole United States, but this is the number of people, look at the dark area, more than 35% of the population being obese. That is the white population in the United States. That is the Hispanic population, much more. And that is the Black population, much, much more. And so we have a long way to go, and we need to stop with fast food every day. We're going to pay for this over a long period of time if this continues in our younger people. The larger amount of, it's not just the content, high fat, French fries and the like, but it's also the quantity. It's way too much. Can we intervene with diet? We certainly can. We can, a variety of diets have been tried. The best ones for the longest and most sustainable weight loss are actually the plant-based diets. And if we look at diabetes and hypertension, we notice, number one, that they're both on the list for cardiovascular death around the world. It's not just the United States. And yet, if we look at the data from large databases, such as the Adventist Health Study, what we find is that the people who are eating the more plant-based diet, vegans, ovo vegetarian, even the pesco-vegetarians, have much less obesity and overweight, defined as a body mass index of greater than 25, less diabetes, less hypertension. And of course, the safest by far in their population observation data is the completely plant-based diet, the only group that isn't overweight. It actually does impact mortality, about a 30% reduction in ischemic heart disease mortality if you're doing a plant-based diet. And the longevity is shown on this slide. That is, more people as they get older in their population are plant-based because they're not dying as fast as the people with that standard American diet in red. As it turns out, the vegetarian population actually does live substantially longer in the Adventist Health Studies, and they're lighter, they're having more life in their life, not just living longer. How about blood pressure? It turns out that if you do a plant-based intervention, you will lower the blood pressure substantially in your patients. And so this is something that we all should be taking advantage of because it's very simple to do. It does take a team of effort, a lot of education, but once you're able to get the patients to do more plant-based nutrition, you should be able to get their blood pressure down. We've seen that with the DASH diet, lowering the sodium, more fruits and vegetables, lowering the cholesterol, blood pressure falls substantially. So it's in our guidelines for hypertension to do physical activity, cut the alcohol, lose the weight, increase the potassium, decrease the sodium, and make sure in green that you're doing as much in the way of fruits and vegetables and whole grains that you can, and that will lower the blood pressure. Let's talk about sugar for a moment, because there's one thing that we all need to know, and that is the glucose, sucrose, fructose, refined grains like the white bread here. They all induce a dose-related insulin response. And insulin is not our cardiovascular friend. It results in more insulin resistance because of the fat cells that are generated, more hyperinsulinemia, which accelerates atherosclerosis by increasing multiple risk factors. And so there's good evidence that as we consume more saturated fat and more sugar, that it increases our cardiovascular disease. It is dyslipidemic and associated with more glucose intolerance, and you can reverse all this if you lower the sugar in the diet. One thing that has to be called out, because everybody seems to be doing it, they're doing sugar beverages, and some of them they think are healthy because they took their fruit and put it in a juicer. But any kind of drinking calories that has a sudden sugar load will actually not just increase your insulin level, but it also increases inflammatory markers, which sets you up for cardiovascular events. The added sugar is associated, therefore, with increased mortality in a curvilinear fashion. We ought to reduce it substantially. Our Nurses Health Study actually did point this out years ago, that sure, nurses die when they're diabetic and when they're smoking, but they also die when they're eating cholesterol, a hamburger, for example. But the glycemic load of a donut is actually worse in terms of correlating with mortality than that hamburger would be. So we have to be careful with the sugar. If we actually look at how plant-based diets relate to the development of diabetes, we see very clearly that the more plant-based you are, there's a linear reduction in the risk of diabetes. On the other hand, if you do an intervention with plant-based in the diabetic, you can lower the hemoglobin A1C substantially. We shouldn't leave out the rest of the diabetic population. That's more than just their A1C and their cholesterol, but general health, quality of life, depression, all of them actually improve when you do a plant-based diet because people are feeling better about everything. We have to consider the effect of sugar-sweetened beverages at the workplace, because there's a good amount of data that it correlates with death, and that you can, if you do a ban on it, you can actually substantially reduce the amount of sugar-sweetened beverages that people are taking in. So our diabetes concerns with refined carbohydrates and sugars, but also with red meat, a diet that is devoid of animal products and low in saturated fat and polyunsaturated fat substituted for sugar will lower your diabetes. Now, I wanted to spend a little bit more time talking about interventions on cholesterol, but I'm going to boil it down to one study that we did to try to match up with our nutrition recommendations in the 2019 primary prevention guidelines. Hopefully everyone will pull up that document and get all your patients and yourselves to follow it much more in the way of fruits and vegetables, replace your saturated fat, reduce cholesterol. You can reduce it to zero by doing a completely plant-based diet and making sure that you minimize or eliminate the processed meat, refined carbohydrates, and sweetened beverages, and avoid the trans fats, which are no longer legal in the United States. We actually did this intervention at an African-American church that was kind of famous a few years ago because President Obama went there. And what we showed is that we can lower the lipids, but not just the lipids. We lowered with a 5-week intervention of completely vegan diet and 50 volunteers. We were able to lower the hemoglobin A1C, the insulin levels, the trimethylamine N oxide. If you're not familiar with TMAO, please look it up. It's one of the things that everyone should know. It should come with a warning label after you read it in the New England Journal of Medicine and all the subsequent data about heart attack, stroke, death, and heart failure. You will likely be a plant-based dieting person to avoid TMAO. Anyway, we had a 43% decrease in TMAO levels in that population, as well as the marked improvement in the lipids and inflammation levels, all of which has been shown before with plant-based interventions such as the Portfolio Diet at University of Toronto. So our heart program, we extended it at Rush to an intervention with 5 weeks in an at-risk African-American population. We were able to show with pretty good adherence that we had multiple markers of improving cardiometabolic risk. We were actually plugging in the data into our ACC risk calculator. And what we showed is that we could eliminate about 19% of that 21% increase in events in African-American adults. So I would say then in closing that our heart disease mortality really continues to increase around the world. You know, the United States is the only high-income country that still has a heart disease as the leading killer, but it's here. It's more prevalent in the underserved populations such as African Americans because of the social determinants of health being worse in that population. It's driven by the diet, the exercise, lifestyle choices, and mediated by an increase in obesity and type 2 diabetes, as well as cholesterol. If you do more plant-based nutrition, you're going to see some substantial reductions in the weight of the population, as well as type 2 diabetes, longer life expectancy, and less of so many diseases that we're treating every day. And for those who are not eliminating the diseases, they're improving them. So in this dual pandemic, we really need to be advocates for risk factor reduction for ourselves, for our families, for our communities, for our patients, for our entire country. If we're able to do that, we should be able to reduce the mortality associated with both cardiovascular disease and COVID-19. Thank you so much for your attention. Looking forward to further interactions.
That was a fantastic presentation. Dr. Kim Williams is the James B. Herrick Professor of Heart Research at Rush University and Chief of Division of Cardiology at Rush and past president of the American College of Cardiology. He was my mentor as a fellow, and I can say without him, my life would not have been as rewarding as it's been, and that reflects his life of service and paying it forward. So Dr. Williams is here live, and I see Dr. Athena Pappas has also joined us. Hi, Athena. And so I'd love to open this up for discussion. And while we're waiting for questions to come in, Dr. Williams, I am intrigued by the notion that these vulnerabilities can be possibly predicted and mitigated by lifestyle and nutrition. My experience is that patients are open to these changes if we provide them with resources and rationale. Can you share what your experience has been clinically at the bedside?
So, hi, James. Thanks so much for the invitation. I'm going to be a little hovering because I'm rounding on the inpatient cardiology service. But I would say that the bedside approach really does require you take the time to assess where the patient is, who's doing the cooking, what opportunities do you have for exercise. That is, we can't just give them a bunch of recommendations and walk away. I always like to say that you're taking the time with them. You're also giving them tools. One that I would like to tout openly is the Association of Black Cardiologists recently published a Heart and Soul cookbook. It's available on the web, and everyone should be downloading it and giving to their patients. It's pure plant-based nutrition, very well balanced with the help of Daphne Ferdinand and Baxter Montgomery in Houston. So you give them the time, then you give them the tools. Then it's also helpful to have a team, have nurses and nutritionists who understand plant-based nutrition, and the rehab people who can coach them on exercise. And if you're able to get that team functioning and have some accountability and some camaraderie, the bedside and the clinic go actually very, very well.
We had a few presentations on mitochondrial dysfunction and heart failure with preserved ejection fraction. Do you see a role for this lifestyle approach with those disorders?
Really did. I didn't have too much time to go into it, the TMAO data from Cleveland Clinic, but the correlation between TMAO and heart failure mortality has been very well elucidated by them. And that was leveraged into a recent publication by Kyla Lara, who moved to Mayo Clinic. She actually took a look at the Regards database, where they had, pretty much plant-based versus all other kinds of diet, particularly the Southern diet. And what they saw was a 41% reduction in heart failure readmissions. This is amazing, just putting people on a more plant-based diet. So you're talking about diseases that can really be sometimes reversed, but definitely mitigated in terms of, the readmission penalties I mentioned are just the first thing people should do with a heart failure admission is change the diet, absolutely.
Dr. Coley?
Yes, thank you, Dr. Carter. Dr. Williams, I really enjoyed your presentation very much, both the social determinants as well as the plant-based piece. So I have several questions for you. The first is, I'm myself in plant-based, and I often get this question from friends, colleagues, and patients, which is, what is the scientific data on meat substitutes? Is that something we ought to be recommending to our patients? Are they high in sodium? Do we have scientific literature to really guide our recommendations to our patients?
You did a great job setting that up. The really important point is that meat substitutes are not all the same. Every single one of them is in fact different. And there are three things. You named one of them. That was the sodium. The next two are saturated fat, which can be high, particularly if you use coconut milk or coconut oil as a substrate for making it more tasty. It turns out that the high saturated fat will increase. We have a wonderful American Heart Association advisory on that. We should not be feeding people saturated fat. I know there's some controversy in the plant-based community that coconuts are great, but I think we have to stick with what happens to the LDL cholesterol, which is that it goes up. The other side of it is believe it or not, heme iron. That was pointed out by the NIH-AARP trial as one of the three big determinants of mortality when people eat meat, and they shouldn't be eating it because of the nitrates, nitrites, and heme iron. The blood of an animal, turns out that heme iron causes oxygen radicals that can then upset plaque, and those reactive oxygen species are associated with myocardial infarction and death. So that's one of the, we're always talking about meat is bad for you because, cancer proteins or whatever. But heme iron is probably one of the major issues that happen when people actually eat red meat or anything with blood in it. So anyway, the reason I'm talking about that here is that there is one product that's become very famous in the plant-based meat world that figured out how to genetically modify a bacteria to infect a yeast to make heme iron. And that's why it tastes bloody, and that's why Americans like it. But it really isn't until they prove that this sort of the fake heme iron is not the same as real heme iron in terms of plaque development and plaque vulnerability, we probably should be avoiding it.
Thank you so much. And my second question was, obviously there's an underrepresentation of minorities in clinical trials, especially of the Black population because of the Tuskegee syphilis experiments. And this has really become a challenge in the COVID era, especially as we're thinking about vaccine therapy with very few minorities enrolled in the vaccine trials. So what do you do at the bedside to encourage your patients to participate in clinical trials? And what can we take away in terms of what we can say to our patients at the bedside to really start to transition the thinking in the minority community about clinical trials?
This really has to be a community effort, a public health, public service announcement. What you're saying is amplified very much by the polls that say that African Americans are 50%, more than 50% of them are saying that they will not take a COVID vaccine. Really? Well, the interesting part of this is you mentioned the Tuskegee experiment. That really still has, you look at the waves coming, the wake of a boat. This is going on for decades now, and it really is true that, and the way it's playing out, you might have seen a recent publication, maybe about 6 months ago, that actually examined the role of African-American physicians, particularly African-American male physicians, with the least compliant and adherent group that we have in the United States, which is African-American men. And it turns out they were 60% more likely to follow the recommendations of a doctor if they actually were coming from an African-American male physician. Now, we're doing our best with the ACC pipeline. We're going to historically Black colleges and universities. We're starting with like the Common Ground Foundation with the 5th graders and the 7th graders and the high schoolers. It's going to be quite a while before we actually have the substantial number of African-American physicians to take care of this, having people get recommendations from people who look like themselves. Therefore, we have to have the leadership in the community going out, getting out in front and saying, this is something that we need to do to protect everyone, not just the African-Americans. That is, we can't just tamp down. We've seen some of the issues that happen in particular communities. You saw the stuff in New York with the Jewish community. It's really important that those public service announcements get out to get every segment of our population to get control of this pandemic. So I'm glad you asked that. I hope that we can approach it sort of from the grassroots, because coming from the physicians may not be the best and the most effective.
As you can tell, this is quite thought-provoking, Dr. Williams. We have 2 more questions before we introduce Dr. Pappas. The first from Gene Sherman.
Good afternoon, Kim. Good to have you here with us.
Thanks, Gene.
My question is, how do we get various minorities, when they're in practice, in training, out into the communities, to show what role models look at? But also I would suggest that we use retired physicians, whatever their race, ethnicity, or gender, to go out and speak to disparate populations about healthcare careers, and that way we can encourage more. Like you say, it will take decades for those to flow out into the jobs, but that's what we've got to do to encourage disparate populations to consider healthcare for career opportunity.
So a wonderful thought, and as ACC members, I'm sure you're aware. That's not my patron. So I'm sure you're aware of the fact that we have a senior physician section now, and so we really should leverage the experience and hopefully the availability of our senior physicians to go out into the community and meet with groups. And I agree that it's important to do this, even if it is if it's an African-American going into a Hispanic community. I think it's much important to be facing the kids and talking about cardiovascular medicine as something that they could do for their career. So thanks for that comment. Dr.
Kondapalli.
Thank you so much, Dr. Williams. It's great to see you. I also want to say, as a former mentee of yours as well, you have helped so many women in cardiology become cardiologists and academic cardiologists.
Thanks, Livonia.
Yeah, it's great to see you. Thank you so much for being here. And I'm not at all surprised that you're rounding at the same time that you're giving this talk. Some things never change. But my question is, what do you do? How do you approach plant-based eating when someone lives in a food desert? I struggle with this. I don't know what's realistic, but you know, if there's no access, have you had any good advice on how to negotiate that conversation?
So, you know, this is a question that I get a lot. And before I took this job at Rush, I was actually living in downtown Detroit. And I was one of those people that actually had to drive to the suburbs to get food. And so, but I had a car, I had a job. It was not a big deal, just a little extra time. The neighborhood stores had very low quality produce and very high prices. And so there really was a food desert. Well, I don't usually call out brand names or companies, but you could probably figure out which one I'm talking about. They actually went to downtown Detroit or Midtown and said that we are not going to have our historically infamous high prices. We're going to come in with very low prices, and they did extremely well. Well, fast forward a few years later, I'm back in Chicago, and my old neighborhood, Inglewood, where the life expectancy is about 20 years less than it is in Streeterville on the north side. It turns out Inglewood now has one of those chains. They figured it out in Detroit, and I'm sure they're going, you know, so you need corporate America to help solve, and trust me, profit motive actually, to go into the food deserts and make it better. So I looked at a lot of the food desert ideas, and people are talking about food deliveries, which is actually a big deal during COVID. And so that actually is one thing that makes it a little bit better. And the expense of it is not overwhelming to do that like it was a few years ago. But if communities, the other major solution is having communities so concerned that they put up the sort of the food basket and the food pantries. And so we need the churches, we need the community groups, fire departments, everybody getting on board to make sure that there's availability of fresh fruits and vegetables at a reasonable price. Because one of the problems that we have that hopefully everyone recognizes is that our government subsidizes foods that are not healthy. I just promise that I don't, you know, bring out brand names, but I got to say this one, the Hostess Twinkie. It's famous because it has 14 different elements that are subsidized by the U.S. government. And it's basically, you know, high fat and refined flour and sugar that will actually hurt the health of the population, which you then have to go pay for with Medicare. So, you know, there are people in Congress who want to be rid us of those billion-dollar subsidies. Hasn't gotten so far.
Thank you very much.
Thank you. Tying into our discussion with respect to mitochondrial dysfunction, there's scientific evidence that nutrient excess triggers mitochondrial dysfunction, and we have a question from the audience as to whether you ever advise intermittent fasting or any type of caloric restriction type food plans with your patients.
I do, and it turns out that there are some people who find that just an easier approach to lowering calories, and whether they stop eating at 4 o'clock or starting it at 10 o'clock, just limiting the number of hours, limiting the opportunities, and sticking to it, and then they look forward to their next meal when that time comes around. I'm not sure what it is that makes that much more attractive to people, but it definitely works. And I would say that any approach that lowers calories works pretty good. Until last week, we were saying that intermittent fasting was working because they weren't eating late when the metabolic rate had dropped, cortisol has dropped. You eat late and you store more calories. But there was an article published last week that said, nah, that's not true. It's just about the calories. So when you cut the amount of time that people are eating, you cut their calories, and it's working. So regardless of the mechanism, if we lower the calories, it really will work.
Thank you so much, Dr. Williams. We really appreciate it. I'm going to turn it over to Dr. Cleveland now.
Thanks, everyone. Really appreciate it.
Thank you. That was absolutely fantastic.
Good to see you, Kim.
Yes. Hi, good to see you. Thank you so much.
Yeah,
Thanks,
I gotta say,
a lot of synergy here.
Absolutely.
From the old days.
Absolutely.
Dr. Carter, I think, has ties to both Dr. Williams and Dr. Pappas. So this is to James' credit to bring both together. This is great. It gives me great pleasure to welcome Dr. Athenia Pappas to our virtual symposium. In addition to serving, obviously, as our ACC president, Dr. Pappas is chief of cardiology and professor of medicine at the Alpert Medical School of Brown University. She also serves as director of Lifespan Cardiovascular Institute of Rhode Island, Miriam Hospitals, and Newport Hospitals. When one looks at her page on the ACC website, one is obviously struck with her passion for moving the needle regarding our strategic plan in the ACC to improve diversity and inclusion. Before she speaks on this critically important subject, I'll also note that Dr. Pappas could easily live in Colorado, and I think we should probably grant her an honorary membership. She describes her extracurricular passions as outdoors, exercise, and cooking, which obviously fits in well with all of our interests too as well. Dr. Pappas, welcome. We look forward to your remarks, challenging us to focus on diversity and inclusion, a very critical topic. Thank you.
Great. Well, thank you very much. And boy, it's really great to see everybody, including James and Kim and so many others, and Jean, who I see on the screen. And I really appreciate you giving me the opportunity to speak with you today. We are actually up in the mountains in northern Maine, so we're going to go hiking this afternoon. So I'll take that honorary membership. Okay, let me share my screen, and I would like folks to be able to jump in and speak up, and hopefully we'll have some time for discussion. We'll get this to go. There we go. So when I thought about talking about, diversity, inclusion, belonging, health equity, and a lot of what we're doing at ACC, it's nothing new, but why do it? And it's really about member value. And we really sort of need that more than ever these days. And I'm going to start with this photo. So obviously we're not wearing masks. This was the Board of Trustees back in January 2020. So we were invited to Atlanta to Moorhead School of Medicine to have our first on the road board meeting. And it was very intentional as we were furthering our diversity and inclusion program, and had Quinn Capers come and do implicit bias training for us. And it was just a fantastic event. And we had the dinner here actually at the Civil Rights Museum with all the faculty locally. Well, I don't have to tell everybody else that a lot happened pretty quickly after January, or was happening, or was sort of came into focus more clearly, or unfortunately for us. First and foremost was COVID. But I want to focus not on the negative, but on the positive here. So, wow, what did we do? We came together. We came together quickly. We did this across borders, and stood up the COVID hub, where the group within 24 to 48 hours would sort through data and get guidance, not guidelines. Didn't have time for that, but got that up on the web. So the world changed fast, but I was incredibly impressed by how everybody came together and got information out. There's still about 2 million people that have visited this. And then pertinent to our discussion today, another wave, nothing new, but just shocked us again. If we didn't know that COVID had shown sort of a bright spotlight on health disparities, then there was racism and violence that resurged in this country. And again, ACC, we got a call from Michelle Albert on a Friday night from ABC, the Association of Black Cardiologists, and said, we need to do something, and will you join us with Bob Harrington, HA, in denouncing what's going on? And we, of course, did quickly. I'm going to talk a little more about that, because as I mentioned, we were on the road for D&I, and we just felt, now we needed to do this more than ever. And not that we were pivoting somewhere else. This was embedded deeply, but it may be more aspirationally in our strategic plan for 5 years. All of DI and E is embedded in our mission, our vision, our core values. It's about our patients, right? It's teamwork and professionalism. And this is what we're talking about in excellence. We can't get to excellence without a diverse workforce and an equitable workforce. I'm going to highlight a couple of things on strategic plans. Don't expect you to know all this. No test at the end, I promise. But look, this was pulled out, but still, and why we launched the D&I task force. We wanted to increase member diversity and inclusion, well-being, and over here on the right, you'll see the focus is also on leadership development. So every aspect here was working towards this goal. So who are we today? And a lot of this is intentional. As we all know, in everything we do, we don't get somewhere randomly. Sometimes you do, but you'll get there faster and hopefully better if it's intentional. So we're 54,000 members, right? Who were we? Well, just 20 years ago, we were 26,000 members, pretty narrowly focused. I could put other representational issues in here, but very intentionally expanding, not only globally, but our whole care team. So a big difference in 20 years. And that was just around membership, right? Now, over the last few years, as we thought more intentionally about who we are and who we should be and what to do right, and Dipti sort of talks about this, and that's why I borrowed this slide from her, that we were, at 1.0 when we launched this a couple of years ago, just understanding thoughtfully what the D&I principles were. Kim Williams and Pam Douglas, Clyde Yancey, and Minna Walsh were the co-chairs of this. And then what are the workforce issues? What are the business case around D&I? And so launching that task force. As we moved over the last couple of years into sort of D&I 2.0, if you will, still learning, we all are. Inclusion principles, getting a culture shift, not only within the ACC, but spreading what we've learned out, and then making sure that that is embedded in the strategic plan and operationalizing that, if you will. And then partnering with a lot of different groups who are doing this already, ABC, ABIM, and doing this perhaps better than we, and we can learn and do much more when we say things together. I would say that we're now moving into 3.0, and that's something I wanted to talk about that you asked me about too, a broader definition, including disparities in equity and moving from this periphery to the core. It had been felt that that was sort of a big ocean to drink, and I think after the COVID and the highlight of the disparities embedded in there, which were always apparent within cardiovascular disease anyway, and then the racial violence, it was imperative ACC that it is in our mission, and we needed to do something more than just write the letter, and we can do that, and we can do it effectively. So I'll talk a little bit about what we're launching and what we hope to do to really make a difference. So the D&I launch really looked at the field. So I think, as Kim mentioned, there is very good data that a diverse workforce, there's a business case for that, and it's not just in medicine, but patients respond. It makes for a much better, thoughtful board, but it's not, you just don't do it without intentionality and being accountable. And so from the deep pipeline to recruitment to retention and leadership. So we have to start and work at every part of our entire workforce and maintaining that workforce and promoting that workforce and retaining that workforce. Not easy. We needed data, benchmarking, transparency. When I chaired the annual meeting 5 years ago, and we wanted to have more diverse panels, we wanted to have more inclusion of our team members, I said, well, what do we have right now? And the answer is, well, we don't collect that data. So if we don't know where we start, we don't know where we're going. So we started on that in a lot of different areas. And it's all about our core values. Here's another example. We talked about what the different aspects we're doing. And it's leadership development. Great to get in. And I think I'm looking at other people who were mentored by people, but you need the tools and you need some mentoring. So this is a clinical trials research. So if we want to have diverse groups within our studies, our clinical trials, not only do you need the people thinking about it and asking the right questions, so we don't have type 3 errors, if you will, but also it helps with recruitment and retention of study participants. So the first cohort was aimed specifically at women in cardiology and women in clinical trials. Very few women are PIs or on some of the advisory boards. Same is true then expanding that out, of course, for all historically underrepresented groups. So this is expanding over the next couple of years to include training clinical trial researchers. This is an interesting thing looking at HUGs, which is historically underrepresented groups, and the leaky pipeline, because there are multiple places where people never get in, and it might be different for different groups, whether it's Hispanic, Native Americans, African Americans, so working as we can, where our strength is, partnering, middle school, STEM college programs, medical school, internal medicine, cardiology fellowship, and then leadership. We have to work at each of these pieces where we can. Let me talk about a couple of those. Kim mentioned some of these deep pipeline outreach, and this is where the governors and the different chapters came in with great ideas and local engagement. So over 2,000 ACC med students have joined, and about over 20% are underrepresented groups. Some of the state chapter sections have had grants to do local pipeline development. A lot of this work is done locally, and that makes sense, correct? And then student outreach with local community organizations, including here you see the Posse Foundation. So local outreach has been very effective with support and sharing of ideas from ACC. Let me pivot then a little bit from the diversity, inclusion, and belonging. So just being included is nice, but belonging is important as well, to equality, equity, and justice. And Rana, who is the Chief Diversity Officer at ACC, gave me this slide, and I like visuals, and now I get it. So equality is sort of an assumption from 20 years ago. Everyone benefits from the same supports, so equal treatment. So that's nice, but not everybody gets to see over the wall to see the soccer game, but everybody got some supports. Equity, everyone gets the supports that they need, and now you can see that everybody gets to see over the fence. This was sort of a concept similar to affirmative action, if you will. It does produce equity. But where we really want to go in the modern or newer way of thinking is justice. So all three people can see because we've removed the barriers. So the next step is we need to do each of these, but then we need to remove the barriers so that everybody can see the game without accommodations because the cause of the inequity was addressed. So this gets at some of the systemic barriers and systemic racism where we need to work as a whole to address that. So I'm a visual person, I'm an echocardiographer, so I got the visual here. Kim talked a lot about this, and as we move into the health equity world, understanding the impacts of the social determinants of health, we know that socioeconomic factors play a significant role, the physical environment, healthy behaviors, and then healthcare. So not to throw up our hands and say, oh, gee, we're just a small piece of the puzzle, but as was talked about earlier, how can we impact and collaborate and find partners around things such as food deserts? And so if we understand that 20% of a person's health and well-being is related to access to care and quality, but these other pieces are so important, it's incumbent upon us as healthcare professionals to partner, speak up, and do something about this 80% that affects health outcomes. So we launched the task force for health equity this summer. Dipti Ichipur it's important enough that the vice president is going to chair this, and the co-chair is Paul Douglas, a prior board of trustees who is in Atlanta. And the concept is, how are we going to get there? The idea that equity is going to be when everyone has the opportunity to be as healthy as possible. So it's not just getting it, it's the opportunity to have that. And what are the pillars that ACC can work on? 3 big buckets: education, advocacy, and science and quality. So we are going to continue to build this out over the next year. So look forward to some things that we're doing, and we welcome ideas, input, and people to implement some of these over the next couple of years. This is, I think, a really useful quote to help frame things from the Sullivan Commission on Diversity in Healthcare. And it really calls for these partnerships and collaboration. And I'll just read the quote because it's powerful. The fact that the nation's health professions have not kept pace with changing demographics may be an even greater cause of disparities in access and outcomes than the persistent lack of health insurance for tens of millions of Americans. So we know that that is an issue, but the consistent lack of diversity is an equally important piece, and that was from the Sullivan Commission on Diversity. So we've been called upon to do this, and I think we have the resources and the will to do that. One of the things that we've already launched, as I mentioned, is implicit bias training. Quinn Capers does a phenomenal job and spoke with the board about this. We all show up with bias, understanding them, recognizing them, and finding a way to combat them is important. So we're training all of our leaders. And the next is to train the trainer so that we're going to launch the first cohort. And then the goal will be by by year 5, we'll have trained over 2,000 leaders who can then further work on implicit bias training in all of our areas, whether it's practice, industry, or academia. These are just some of the modules in education. So we talked about some of the ways that we can be effective in our big buckets of what we do well. So around education, a number of completed modules looking at healthcare disparities. There were some phenomenal webinars that were put on this summer, which are still on demand. And if you haven't seen them, I would encourage you to do so. Looking at mental health of African and Black Americans. And then in development, working on sexual and other harassment, what we need to know, micro and macroaggressions, some of the social determinants of health, just educating all of us so that we can listen better and learn better and attack this and help this. The advancement of women cardiologists, the implicit bias I mentioned, how to talk about racism and be effective in that, and a guide to racism, race, and ethnicity. ACC and HA are working on a professional statement, a section of which will be about health, equity, inclusion, belonging, diversity. So I obviously get very excited about that. It's a piece of our entire member value, whether it's our quality tools, embedding this in our quality tools, our education, research, and publications, making sure that we're careful as we review things, and our editors are diverse as well. Public policy, man, our advocacy team's amazing. We just had LEDGE conference, and we have health advocacy embedded in the new task force. The conferences and communities that need to continue to be engaged and leveraging some of those relationships, and then continuing to gain leadership skills and support career advancement for everybody. And what's more important, the BOG and our local chapters, it's really crucial. We're really unique, and it's kind of neat that we have this group that is, connected locally as well as nationally. And so the listserv, I don't know if you realize this, but it was the listserv early on where people were exchanging questions and concerns. We were, building the plane while we were flying it during COVID, but those responses inspired a lot of the COVID hub. So it really was this connection that sort of helped build this, whether it was what to do about QT prolonging drugs, how to get work excuses, telehealth, and some of the advocacy. The parity around telehealth was really a phenomenal win. A lot of the webinars and summer series, again, it came from the energy that we found and the questions that were being asked that we could quickly respond to. And then I'll just, also mention the chapter and section grants, because the idea is let's get some pilot funding and really do innovative things and do them fast. Since we just had our LEDGE conference, I did want to mention, and I'll be honest, until I was president, I didn't and had to sign off on all of these papers, how much we were actually doing. There's over 10,000 messages that ACC members have sent on to Congress. We've had lobbying days. There's now much more, I think 25 advocacy statements that are submitted. So everything that might touch on us is reviewed, updated. The health advocacy team, Gene Sherman can speak to this, reviews this and has something to respond to Congress. That means they come to us with questions too. So I think these are important because it allows us to speak as a single voice to help make change. And I like the saying that we're owning the problem and advancing the solutions. So I'm ending with telling you what everybody knows, significant environmental change this year. And it does seem overwhelming at times. I think we can all say that clearly. And this is just some of what we felt, both the financial stress, the emotional stress, but it's up to us to try to help solve that and support each other. And this is really just a short summary, as I've mentioned. So what are we doing? What do these changes mean for ACC? Well, we have to continue to evolve and adapt. making sure we've got guidance and education available to people, shifting to virtual meetings as we are today, focusing on well-being. We really need to take care of ourselves and learn how to do that for others. And then this focus on diversity, inclusion, and health equity is crucial. And across the college, really dismantling some of the underpinnings of structural racism and disparities. So with that, I'll end. Would love to have a conversation. This is a quote from one of the founders of ACC, which particularly in this day and age seems meaningful, and that is, we will meet the future not merely by dreams, but by concerned action and inextinguishable enthusiasm. So I feel like that says a lot about who we are. So I'll pause. I would love to have comments, questions, guidance from you. Thank you. Thank you, James, for inviting me.
Thank you so much for sharing your thoughts. I love the focus on being aspirational and intentional. I'd like to introduce Dr. Pyle Coley, who will help lead a discussion and reflections. I think it's appropriate at this time. Dr. Coley is a Colorado native and a non-invasive cardiologist with Bachelor of Science degrees in biology and brain and cognitive science from MIT. She graduated magna cum laude from Harvard and finished cardiology training at UC San Francisco. She holds advanced fellowships in preventive cardiology, echo, and in clinical research. She loves writing, and we are often comforted by seeing her in her critically important role as the on-air medical expert for Colorado's 9 News. Dr. Coley.
Thank you, Dr. Carter. And Dr. Pappas, I have to say, what an incredible discussion this was. You know, I've been so moved by the American College of Cardiology and its leadership, not just obviously during this pandemic, but in general, really being a trailblazer in changing the way that we think about medicine and practice medicine. So thank you for your leadership and for being here today. I am curious, I want to share with you that, you know, as a woman of color in the field of cardiology, I feel like there's often a disconnect between what we talk about with diversity and inclusion and what happens in the real world. Who gets promoted, who gets certain jobs, who gets put on leadership committees. There's a real disconnect. So what advice would you have for really bridging that gap so that we're not just talking about it, but we're implementing it in our everyday practice? And you know, what can we do in our practices to really try to help bridge that gap so that there isn't a disconnect between what we say and what we do?
Absolutely. I think that's a really important point, and that saying something is nice, it's aspirational, but then we need to do something. And like a lot of what we do, we need to know where we're starting, know what the problems are, and then address them one by one. And I think that's what the D&I task force really has started, and the Health Equity Task Force will continue in that realm as well. And that is, what is the data currently? What do we know, and who can we partner with to train women for all of those different areas, to train underrepresented groups in all of those different areas, whether it's research, leadership, making sure that we're looking at competencies, and that implicit bias training happens. We have our nominating committee coming up for all of the positions, for example, in ACC. There's implicit bias training in all of the nomination process as well. So we need to understand what the pieces are that have held us back or made us think we're doing a great job and we're not. And then work on that and know that it won't happen overnight, but we need to be consistent, and we need to measure it, and we need to go back and fix it again if we're not on that track. And we need people to speak up, and we need, I think, you know, people such as yourself and the others that are on this call to help guide us and to listen.
You know, I was really struck by your equity, equality, and justice, because that really means removing those barriers, as you said. So have we identified any of those barriers to this point, or what's emerging in terms of what's been the biggest obstacle?
Yeah, great question. I think, you know, as we learn, depends where we're talking about, and it's different for different groups. And I think that's the other thing that I've learned and that we've learned is there might be a different barrier for women. There might be a different barrier for an African American. There's a group that has spoken about a group of Asians feeling there's a sticky floor, that they get stuck on the floor. They get in, but they don't get to move to leadership positions. So is not a one size fits all, I think is the first important piece. And that the barriers that get identified might be different. So we lose a lot of people in middle school. So if people don't see somebody and think I could be a doctor, I've seen, a black man in a white coat, then they might not think of that next step. I think that those barriers, as they get identified in specific areas, then we can organize around those.
I think that's great. And I would encourage anyone who's listening to ask questions using the chat feature to Dr. Pappas. So Dr. Pappas, what do you identify as the biggest challenge moving forward in terms of really shifting this needle?
It depends what we're trying to shift, I would say. So shifting, the diversity and inclusion, we're a little further along on. So making sure that we have competencies, that we have rules of engagement, that we're training people to do that. The health equity feels like a bigger ocean to drink, but what are the specific things that we can do, whether it's around training people, whether it's around advocacy, and then education. What are modules? For example, Rob Roswell is on this health equity task force, and he's on the board of the ABIM. Should there be specific modules within that where you have to have that knowledge base? Getting at some of the structural problems in our test taking is another piece which would be important to tackle as well.
I want to shift a focus a little bit and talk about clinician well-being and burnout, because that's such a big part of especially the younger physicians that are finishing training. And I've often wondered what factors are contributing to it. Obviously, there's electronic health record, the administrative burden, the long hours. But, what's your outlook on that? And what advice would you have for young clinicians or those who are starting to feel effects of burnout even late in their career?
Oh, great question. And Laxmi Mehta has some nice data on that, both in JACC and other articles, both in getting information from our life survey of men and women, and what are those factors. It's some pretty typical things that aren't unique to cardiology per se, but it's control. It is the health records, so the electronic health records. And some of it is family and other stress. And so making sure that not only are we talking amongst ourselves to control that, but working with, say, MedAxiom and other places where there's administrators there, so that we have them as our true partners in solving this, that just asking physicians to do more, or nurse practitioners or nurses to do more is not effective. So making sure that we have, and the advice would be making sure you have somebody you can go to speak up about, looking at mental health and support, so that it's not such an onus and a black mark on you to have sought mental health treatment. You can see sometimes when you have to fill out those forms that you're asked that question. And so how do we allow that physicians can take care of themselves and seek help and support each other? And some of it is learning, all of us learning, how to be more supportive, how to speak with better EQ, how to give feedback that is positive, and having a place where people can go when something, that's a safe place to complain, whether it's a microaggression, a macroaggression, harassment, that you feel that. And then I think the last piece is, Pam Douglas and others wrote compensation data, knowing what the transparency is. So here's what it should be, and you should be able to ask those questions, and it's incumbent upon us to try to get that information out so that you have the tools and the information to do that.
I think that's great, especially during COVID-19. We've really had such a rise in mental health issues, not just obviously amongst patients, but also amongst providers. And this whole concept of our social immune system has come up. So it's not just our physical immune system, but how do we keep our social immune system healthy, and really start to think about that as a priority as well. I wanted to ask you a little bit about telehealth as well, because as you've seen with the pandemic, we've really had a shift in looking at Medicare databases. You know, initially we were doing almost exclusively in-person visits, and now we've rebounded back to the level of in-person visits that we had before all this started, but we've also added a substantial number of virtual visits. So my question there was, what is the ACC doing to kind of facilitate telehealth moving forward, both in terms of access and in terms of reimbursement to providers, which, you know, there's speculation that CMS may decrease reimbursements for those.
Yeah, great question. So one of the top 4 things when we went to lawmakers, you know, ACC, we get together and there's like 20 things we could ask for. And one of the top 4 things was specifically about reimbursement around telehealth, and making sure that there's parity and how we might balance the audio only versus audio with video, knowing that that actually can be an issue around broadband and access and disparities, because whether it's older people or people who don't have a smartphone or access to that level of technology can only further worsen disparities. So one of the concerns is making sure that that is an option, making sure there's oversight. So we're advocating for that for sure. We have partnered with Heartbeat Health, which is a cardiologist who actually helped build something which makes it more than telemedicine, but telehealth. So how can we use our innovation section, and John Rumsfeld is helping lead this, to link in some of this data so that you can have a more robust virtual visit, whether it's wearables, EKG data, blood pressure data, and some other novel things that might be coming out, whether it's ultrasound machines. So a little bit of, you know, Star Trek-y sounding, but if we're not thinking about it and somebody's not acting on it, but those are 2 big things that we're differently doing.
That does sound like Star Trek, but sounds wonderful. So we do have a question for you, Dr. Pappas, from the audience. So we've talked about the development of a pipeline and also helping to remove barriers. What sort of educational activities do you foresee the college sponsoring in order to do so?
Oh, great question. So in the past, we've had a number of educational leadership. They're small though, right? So a lot of people have applied, whether it's emerging leaders around different areas. So advocacy leaders, emerging leaders, trialist leaders. So trying to build a cohort of people, young people, early careers who have the skills to take the next step within ACC and then externally too. I've learned a lot from ACC and some of that work to go ahead and move that forward. So I think those are some of the big pieces. The other is, for example, even within the ACC AHA writing committee and the guidelines, we just did a guideline optimization. We're going to be putting some of this out in JAC, I think, next month. But one of the pieces was making sure those groups are diverse, finding ways to make sure we have the right voices there, and that there'll be early career in an FIT position. That hadn't been the case. You had to be 100 publication to be on that, but we need those voices, and we want to train people how to do that. So we're working towards training people in peer review and making that meaningful. So I think there's lots of ways each of these can sort of build on each other, and ideas that people have locally, I think, is super important to help train people and give them the tools to be successful.
Well, I want to thank you, Dr. Pappas. This has been such a fascinating discussion. And, you know, cardiology, and specifically the American College of Cardiology, have been the leaders in really innovation and leading the way, whether it's device technology, telemedicine, diversity and inclusion, leadership. So I'm just so happy to be a part of this organization. And thank you again for your time and your insights today.
Well, thank you for having me, and thank you, James, for inviting me. It's great. It's great to see you again. And it really is my privilege. You guys are doing a phenomenal job, and I look forward to seeing you more, and fingers crossed, seeing each other in person in the next couple of years.
It's great seeing you. We know how busy you are, so we're quite honored to have your participation. This has been unbelievably stimulating, and this conversation will go on beyond this symposium, which is the whole point. So thank you so much.
Well, best of luck. You guys are, great chapter. I'm now an honorary member, so I'll come.
That's right.
Awesome.
I think we'll take a 5 to 10 minute break. What's the everyone?
Yeah, what do you think, James? Maybe a 5-minute break, and then I'm going to kind of really condense down my presentation so we can really have, we'll get back on time a little bit. We'll make up some time. So,
All right.
We're only
Thank
about
you.
10
no,
minutes
we're
apart.
good. Thank you.
Thank you so much, Athena.
I certainly can uh, give a very brief introduction. Joe Cleveland, I am our chapter president for the Colorado chapter of the American College of Cardiology. I currently am the Frederick and Carol Grover Endowed Chair in Surgery at the University of Colorado. Surgical Director of Cardiac Transplantation. I guess if you count my training, I've going on 30 years here in Colorado. I came here as an intern, did all my general surgery training here thoracic training here and joined the faculty in 2001. And one of my greatest joys is the ability to interact with people from our groups here with James Lavagna, others. We've got a diverse panel here with Jason Schaffnos today too as well. So, and a patient. And that's why I kind of gonna try to condense my presentation. I'll let everybody know I can make this presentation available via our website if Leanna wants to post it there, or I'm happy to email it, but I'll skip through some of these slides just to try to make up a little bit of time. So let me share my screen. There we go. Everybody see that okay?
Yes.
Okay, great. So this next section will be really a case-based discussion of the hemodynamics of COVID-19, and we will focus on, first of all, I have no disclosures. So this case involves a 54-year-old male who was admitted with 2 days of fever, myalgias, and cough and shortness of breath. This is back just as we were kind of coming into our initial surge here in Colorado, late March, early April. He did test positive for COVID-19. His blood gas on admission was notable for hypoxemia. This is on a non-rebreather, pH of 742, PaO2 of 52, PaCO2 of 35. He was admitted within 6 hours of admission. He progressed rapidly to fulminant respiratory failure. His chest x-ray appeared here. You can see endotracheal tube and diffuse kind of patchy alveolar infiltrates. We were asked to evaluate him for respiratory veno-venous ECMO, and I'll get into just the differences in ECMO support in just a little bit. But we placed him on veno-veno ECMO after he had been paralyzed, had an attempt at prone ventilation. On 100% FiO2, his PaO2 remained in the low 50s with a PA to F ratio less than 60. You should note that he was not a gentleman that saw doctors often. He did have hypertension, and on admission, his hemoglobin A1C was 8, so likely diabetic. His BMI was 30. He was placed on veno-venous ECMO, cannula here through the neck, and we'll talk about this a little bit just without getting too technical, but this was a way to support him. He spent better part of 9 days on ECMO, was successfully decannulated, extubated about 2.5 weeks later, left the ICU to home after about 31 days in our hospital. So to back all the way up, just what is ECMO besides a 4-letter word? And that's what my oldest son used to say when he was about 2 years old when dad would have to stay at the hospital. But ECMO is basically the components of a heart-lung machine. So pictured here is a cardiopulmonary bypass circuit primed and ready to go in one of our operating rooms. This is the, quote, heart-lung machine that really makes our ability to perform coronary bypasses, valve procedures, transplants, you name it, what we do in cardiac surgery possible. And it really consists of a series of pumps, a console to drive a centrifugal pump, which is the bottom here, an oxygenator, and a venous reservoir. So what ECMO is basically components of this. And so here pictured is our mobile ECMO circuit we keep kind of primed and ready at the University of Colorado. It has a monitor and a control. As an oxygenator, we don't have the pump primed into it. We keep it, that could be basically adapted in for about, it takes about 2 minutes for one of our perfusions to snap this in. And then the gas cylinder here is empty as well with oxygen and some tubing. So basically it's components of the cardiopulmonary bypass machine we use every day. Some modifications have been made in the oxygenator to allow longer use of the oxygenator because one of the things that does happen is that plasma proteins, other things, fibrin gets deposited on these oxygenators. And if you don't have specific oxygenators for the ECMO circuit, you have to keep changing them. There are 2 different configurations for ECMO. Veno-arterial ECMO basically is for full cardiopulmonary support. This returns oxygenated blood from the circuit into the arterial system. Show you some pictures in just a little bit since I'm a visual learner too as well. The mode of support for this patient and what is most common in COVID-19 is veno-venous ECMO. It's for pulmonary support only. Again, blood is removed from the venous side of the body, goes through a pump, is oxygenated, and it returns to the pulmonary artery. So again, major difference. This is supporting the lungs. This is supporting the heart and the lungs. So again, this illustration is taken from a review done in JACC Cardiology Heart Failure, showing different modes of central cannulation for VA ECMO support. So central cannulation describes removing blood from the right atrium, sending it through the ECMO circuit, returning to the aorta. Obviously requires some sort of a sternal-based incision, pretty invasive, but sometimes that's what's required. Perhaps the most common way we place people on ECMO is peripherally. So again, blood removed from the femoral vein comes to the oxygenator, returns to the femoral artery, and we often put a little distal perfusion cannula. So the blood actually returns retrograde, so the cannula is directed towards, if you will, the central organs, but there's often a small retrograde distal perfusion cannula. We will sometimes support people, particularly people that are waiting transplant, with peripheral cannulation via the internal jugular vein and axillary artery, so they can get up and walk. Obviously, when they're cannulated in their leg vessels, they can't walk. Veno-venous ECMO has been around for quite a while. What was the classic veno-venous ECMO was two cannula, one in the lower, that is coming up the IVC from the femoral vein. Blood was withdrawn in this cannula, again, sent to the oxygenator, and then returned via another cannula in the neck. And so this is, again, the blood comes back this way, receives oxygen, is returned through the right atrium, right at the tricuspid valve. Well, there are now two commercially available cannula that can be used as a single cannulation system, again, to have only one cannula in the right internal jugular vein, blood is withdrawn from the central lumen of this cannula, taken back, deoxygenated blood to the machine, receives oxygen, and is returned in this larger outer bore, again with the outer aperture from this outer system directed at the tricuspid valve. These are large cannula, 28 to 31 French, the size of these, but actually they can be placed percutaneously. Again, the advantage of this is patients can actually ambulate with this. You can actually extubate them and have them ambulate. And so, for example, when we put people on veno-venous ECMO for bridge to transplant, for lung transplantation, they can be up walking around. So I'm going to walk quickly through. I'm going to wind this up about the next 3 minutes so we can turn to our panel, because I see Dr. Schaffnos is here, and also we have our patient here. But as of Thursday, ELSO is the extracorporeal life support organization that has a large worldwide registry. Nearly 2,800 COVID-19 cases were supported throughout the world on ECMO. 38% is the ongoing kind of mortality, which is actually not unreasonable. So again, the majority of these in North America, Europe, a few in Latin America and Asia Pacific, and then a few else in this Southwestern Asia African continent as SW8AC. Important is the fact that these tend to be youngish patients, 50. The vast majority are supported with VV ECMO, as I mentioned, about 90% of them. Most of them have failed conventional ventilation with a PF ratio 70 or less. And then we see a fair amount of patients with diabetes, obesity are two markers for patients not doing as well. I'm going to skip over this other than say this is a recent Lancet publication. Again, from ELSO, documenting about a 38 to 40% mortality, so about a 60% survival, looking at differently for patients supported with VV ECMO. Important risk factors, age. So the older you get, the less well you do on ECMO. At the University of Colorado, we don't have a hard cutoff, but anybody above 60, we begin to really be quite selective with this. And I'll move to that in just a moment. Why? Other things, actually, even though diabetes is a risk factor for not doing as well with COVID, it was not found to be an independent risk factor for death on ECMO. But things having like acute kidney injury, cardiogenic shock when you go on, things like that are important risk factors. So who gets ECMO? So people who have a P to F ratio less than 150, so that is their PaO2 divided by their FiO2 less than 150, usually get proned. They usually have neuromuscular blockade and PEEP given, and they have consideration for inhaled vasodilators and recruitment maneuvers. If their P-to-F ratio is less than 60 for 6 hours or less than 50 for 3 hours, or they're very hypercarbic with acidemia, basically a respiratory acidosis for greater than 6 hours, then if they don't have contraindications to ECMO, they should be put on ECMO. The other way to get into this, as I said, is if you have severe hypercarbia that's causing systemic acidosis. So those are the patient selections. Now, one of the things I wanted to bring up real briefly, and this is relevant right now, actually, in our center, is that when we first surged in March and April, we went rapidly from having contingency conventional capacity, which is capacity exists, we got plenty of oxygenators, we got plenty of ECMO spaces, et cetera. We went from category 1 to category 2. We fortunately never hit category 3 like they did in Italy or parts of New York City, but we were close. So we have about 12 ECMO circuits at our place, 10 formal, 2 that we can kind of cannibalize from using other aspects of kind of saying we're not going to do any cardiac operations that week, et cetera, et cetera. We were writing just about 9 ECMO patients at our max. So we were close. As I'll mention a little bit, we've kind of hit another tier 1 and are almost at tier 2. We're currently supporting 6 patients here now, and it has surged recently. Important contraindications, again, BMI greater than 40, age greater than 65. These patients don't do well. Obviously, they have advanced chronic underlying systolic heart failure. They're very vasodepressor requirement and not candidates for VA or VVA ECMO, then probably should not do this. Absolute contraindications. Mechanical ventilation greater than 10 days is an important one, so getting these patients late does nobody any good. If they've had severe acute neurologic injury or if they're in multiple organ failure. Ongoing CPR is also a group that we did not choose to put on ECMO. Again, this is a COVID review that I'll make available again via the website. I'm going to skip through this. So as I want to move to our panel discussion and kind of get, not cheat our last symposium on time here, to summarize, ECMO and COVID-19, like all things COVID-19, we are evolving, changing. We are still seeing the landscape of ECMO change. However, standard VV ECMO that we have used for influenza, that we've used for other respiratory insufficiency can be applied with reasonable outcomes. The predicted surge in COVID-19 in the fall is here. I'm on call this weekend. I've already received 2 consults for VV ECMO, and it had been quiet through the summer. So please wear masks, socially distance, practice meticulous hand hygiene. We can get through this together. We're not through it yet. We need to continue to do what we know is right for ourselves and our patients. With that, I'm going to exit the presentation and stop sharing. And we've convened a panel. I know Jason Schaffnos is with me. I see Jason there. Jason, I'll give you a quick introduction shout out. Please fill in anything. But Jason is a cardiovascular surgeon at SCL St. Joseph's Hospital. Excellent colleague. Is really thoughtful, and again, I think that he brings a perspective to this that would be very helpful. We also are extraordinarily fortunate to have Jason Johannan. I hope I'm not mispronouncing your name, Jason. He's an ECMO patient, an ECMO survivor that Mike Furstenberg took care of early in the crisis as well. And Mike cannot be here today because of some extenuating family circumstances, but we want to engage Jason's patient-based experience, because I think this is a unique experience for us to actually talk to somebody who's actually kind of undergone obviously a very dramatic experience with COVID and survived. So with that, I was going to start with our patient and with Mr. Johannan, and just give us a brief tidbit of how you presented, what it was that you knew when you weren't well, and kind of what you remember, and hopefully not a lot of the acute phase of this, but kind of your reflections as a patient.
Sure. Thanks very much for having me. Do you hear me okay?
Yes. Thank you.
Well, first, before we get started, I'd like to, on a very micro level, thank each one of you for everything you do on a daily basis. I understand it's your job to be pragmatic and look at the overall numbers and overall health, but on a very micro level, thank you. Thank you for not only the impact that you have on the patients, but also their extending family, friends, and so on. So thank you. So as you had mentioned right at the very beginning, at the peak, I was on a family vacation in mid-March, and we took a road trip down to Arizona with another family. Both of our families, our wives were doing a half marathon in Antelope Canyon. So on the way back, families continued home. My friend and I, we actually went dirt biking in Moab, and somewhere between Arizona and Utah, I seem to have gotten something. So arrived back home on a Friday. By that Monday, I started feeling a very bizarre chest pressure, just like someone resting, pointing their fingers right on my chest. Not painful, but just a very bizarre feeling. And I'm a very healthy guy, but by all accounts, I run marathons and I'm not a drinker, smoker, anything like that, pretty athletic. But I just knew it felt different. And my wife, who is a nurse, I said, this feels different. I've never had any pneumonia before or anything like that. Just, it feels very, very bizarre. She said, oh, well, maybe the news is getting to you and so on. So I don't know, this feels weird. About a day or so later, dry cough started making its way, and that chest pressure continued. On day 3, I finally had a telehealth appointment with my primary care physician. And this was, again, when everything started shutting down. So I couldn't have an in-person meeting. And she said, well, it sounds like COVID, but have you had any fevers yet? No, haven't had any fevers yet. Okay, well, those may start, but we urge you to stay home unless you really have trouble breathing. Okay, fine. Sure enough, that night started having fevers, and I began self-isolating at that point. My wife would come in wearing a mask, would use a stethoscope, monitor my lungs. We already had an oximeter. Oxygen levels were hovering in the low 90s, then the high 80s for a couple days, and I was just fevers off and on. Real extreme fatigue. Couldn't concentrate. Just couldn't read anything. I was taking multiple naps throughout the day, just completely out of it, which was very bizarre. Finally, about day 4 or so, my oxygen level was hovering in the low 80s, and my wife called our primary physician, said, this isn't looking good. Jason's feeling a little bit, this is definitely something different. She says, well, is he still speaking in complete sentences? And well, yes, I was. Fast forward, wanted to again stay home and reserve those beds for the higher risk patients, because again, being a healthy person, I thought I'll knock this out in a couple weeks. And so finally, on that 6th day of self-isolation, I just couldn't catch my breath. Middle of the night, about 3 a.m., I called my wife, who was sleeping in my son's room. We've got 2 young kids, 8 and 4, or 9 and 4 now. And I said, I've got to go in. I monitored my oxygen. It was 77, reading 77. And she said, okay, be right there. And washing my hands were white, and ended up going to first Skyridge Medical Center, and arrived there at about 4 a.m. And within 24 hours, I was intubated. I was put on a ventilator, which luckily I do not remember. And for the next roughly 2 days, a little bit over 2 days, I was being rotated from prone to back every 12 hours. And then I believe one of the compelling moments that caused me to be transferred to MedCenter of Aurora to be placed on ECMO is that in one of the rotations, my oxygen level dropped to 54. And by the way, while I was first admitted, I was given hydrochloroquine and azithromycin, which had no impact on my current condition. So I was transferred via ambulance, and again, I'm out at this point, and placed on ECMO immediately. I was also having a cytokine storm, and one doctor recommended I receive tocilizumab, if I'm saying that correctly. It's one of the tongue twisters there. But it was advised against that as soon as I was placed on ECMO because of all the sites that I had. If any one of those was to get infected, I could go septic. Okay. Touch and go, it's my understanding, for the next few days. And then finally on Saturday, which was about five days of me being on ECMO, they said, well, we need to try something. So I was administered that IL-6 medication, and on Sunday, Easter Sunday, had a slight improvement. And in parallel, I was just approved also for the convalescent plasma trial. And on Monday, I was given convalescent plasma and I just skyrocketed from there. So 2 days later, I was removed from ECMO, monitored on a ventilator for another day. And then on the 17th of April, total of 14 days under, I woke up 2 days before my wife's birthday and experienced what's been termed COVID delirium for the next 2 days, which was a pretty tremendous experience. And I'm happy to share anything you would like about regarding that. But 30 pounds lighter, no strength, but I'm alive. The recovery process was definitely a battle, but I'm lucky to say that I'm almost back to normal today. And it's been a journey. I'm happy to answer any questions the team may have, but that's my Cliff's Notes version of my story. And again, thank you all for what you do.
That is probably one of the most impactful things I've seen in the last several weeks. Thank you for sharing your experience. And I think one of the things that highlights to all of us is that young and healthy can get this just as well as things that we talked about as risk factors, and your journey is unique. I'm going to look for questions in the chat function. While we do that, I'm going to ask Dr. Jason Shopnos, who's one of my colleagues, again at St. Joe's, to give us a bit of a perspective of, again, we have all walks of life, thank goodness here. We have large academic centers, we have busy community tertiary medical centers like Medical Center Aurora and Jason's place. So what was your response to this, and how did you, I know one of the things that we talked about was resource allocation. So how do we make sure that we could be available and have resources for patients like Jason?
Certainly, yeah, definitely. Can you guys hear me okay?
Yes.
Great, okay, yeah, I appreciate being here. Thanks for asking me. We went through a similar thing, I believe, to your program, Joe, where we had the same sit down in the beginning and tried to decide who we were going to maybe consider for this and what we could afford to forego from just a standard surgical sort of program. So we have, at our hospital, we have the ability to, we have, our operating rooms where we have 2 dedicated to hearts, but we have 3 essentially ECMO circuits and another 1 or 2 that we can cannibalize, as you said, to use for this if we need to, not using our heart and lung machines, and still be able to continue with cardiac surgery. So initially we were following kind of traditional ELSO guidelines. And I think it worked out relatively well. When we had our surge in the beginning, we probably had, I think, 70 or so patients in the hospital with COVID, another 20 or so. Our standard ICU was actually completely full with COVID, and we had to move our ICU, and even our hearts were actually recovering in our neonatal ICU, a separate section for about 2 weeks, because we didn't have any more space. Of those people that we had, another 20 or so were on ventilators, being prone essentially. In that initial section, I think we probably had 5 to 10 that we considered for ECMO, but many of them met that criteria of being intubated for over 7 days, morbid obesity, age over, most of them were over 70. And so they weren't really considerations in the beginning. And in fact, when we looked at our data, and I think we've had probably 7 to 10, I think maybe on ECMO. We just got our last person off actually last week. They've all been pretty much 20 to 40-year-olds is the section that our last 2 patients were both 40 and 42. And so, and I would actually say most of them didn't have many criteria that you would actually expect them to have complications, like Mr. Jahanian, I guess I said it properly, but it really were relatively healthy individuals. One a little bit overweight, another one had asthma. That was really it. And so, but we did have that talk about resource allocation. What can we do? And I think normally, with most, when this pandemic isn't going on, our overflow for stuff that we either can't handle or aren't able to do or don't have the technical expertise is you. And so, but in this case, the university didn't have that capacity. Every center, I think, was inundated with these patients. And so it really became a triage situation as far as who we were going to consider and what we could do. And I think thankfully, and I know this is the same approach at every center, with a multidisciplinary team looking at this. Ours is intensivist driven, and they're pretty good. And so I think many times people that we were sort of trying to decide or were kind of teetering on the edge, we were able to actually pull them through with satisfactory results, I think, just from with respiratory management rather than full support. Our sickest patients in the beginning that we did have complications, and our current data, we actually just looked at it, very sort of mimics the ELSO data, and actually it was nice that Lancet article came out recently, because the initial articles in the beginning were that it was, as very poor results. I mean, you probably shouldn't even be considering it. And I think that probably swayed us a little bit in the beginning for who we were going to consider and what we should do. So I think our current practice sort of mimics what that result in that study showed. And I think our sickest patients that we have had problems with have been the VA ECMO patients, because they are sicker with end organ dysfunction. And I do think that's a major contributor to complications with this.
Thank you. It is a humbling thing, because it certainly is. You said, I think a lot of us obviously are in this field because we're used to, we'll take care of whatever we can. But as you said, we really had to put some thought into things. A couple questions coming from the audience that are fascinating, and for Mr. Jahanian, one of our panelists has asked, was your wife able to see you while you were hospitalized? And this must have been very hard on your family or children. So can you comment about that as well?
Sure, absolutely. That was, I tell everyone that my family had a much harder battle than me. In 2 weeks, I was what I call asleep, and they didn't know if I was going to make it, and the odds were against me. So they definitely had a tougher battle than me. As far as me waking up and experiencing the COVID delirium, and I would have waves of reality via FaceTime. I was not able to see her personally or see anyone personally given the COVID restrictions, which is understandable. But I think that negatively impacted my hallucinations and so on. And plus, should see some of the pictures, but I've got all the monitors. I was pretty gaunt, and so my facial recognition didn't work, and my fingers didn't work. I have to page someone to unlock my phone, and it was, and God bless the staff, because they would have to re-gown because again, I'm isolated, so they have to go through the extra precautionary periods. But yes, only via FaceTime. So the first time I saw her was 5 days after I woke up in the lobby of the hospital.
Wow. That's I think we will learn, as we've learned so many things in this pandemic, but I think that's one of the things that's been hardest on us as professionals is also, I know in my own practice, I'm used to communicating to families, and it's very tough to, as you say, on our end too, as well. It's obviously much harder on your end, but it's harder for us just to sometimes have the support that we felt we needed with families to help people this time. I think, Doctor, there was another question from someone on vent support on ECMO early versus late. It was, we've kind of, as I said, as Dr. Schaffnos alluded to, some of the early data that particularly came from New York was really painted a dismal picture. And I'm glad we didn't follow it either, because like Jason, we've had close to 25 patients with, actually, we still have 2 ongoing, but we have 21 survive. So we've got about an 80% survival. And it was interesting. And part of the thing that was so interesting to me about this back in April, trying to figure this out together, is one of my good colleagues, Craig Sells with the University of Utah. I said, well, maybe there's something different about the Rocky Mountains versus the East or whatever. We should put together our combined ECMO experience. And, I thought Salt Lake City, same as Denver, they surged much differently. I mean, they were, when we were in March and April, kind of, Jason said, figuring out who we could operate on and how much resources. They had 1 patient on ECMO the whole time. And then through the summer is when they got hit. So this is one of the things that's been really fascinating, I think, is the differences. I obviously think we could obviously continue this discussion much further, as we could all our discussions. We thank you for being here today. Both Dr. Jason Schaffnos and Jason Jahanian. I will wrap this up because I think we're running currently into our next session's time, and I I do want to respect that. This has been a very impactful presentation by you, and I'm glad to see you smiling and doing well. This is you are the reason that we all are here on Saturday morning to learn from each other. So thank you for sharing your experience with us. It's been very powerful. So, Dr. Schaffnos, thank you as always for your collegiality, and we'll all get through this together. That's all.
Appreciate it, Joe. Thanks for your help always.
You bet. With that, I'll turn this back over to Dr. Carter to introduce our last section.
What we're going to do right now is kind of shift gears, and we touched on it a little bit with this unbelievable input from Mr. Jahanian. We thank you again for sharing this with us, because you started out the conversation with reminding us about what we do and why. And I think that's quite impactful. And I think what makes this so different than what we are used to dealing with is, as you describe this experience, we don't have absolute answers all the time. We can't be definitive, and that lack of definition can impact not just you as the patient suffering, but your family and your circle. And your description certainly highlights that. I'd like to turn it over to Nancy Lundy. And I don't know Nancy well, and I misplaced her bio. So I'm going to ask Nancy.
Because
okay, I'm so
I do know
sorry.
Nancy she is actually one of our CVT team members who's an absolute star in Colorado ACC. I can speak that I know Nancy's, she is a nurse practitioner who engages in the care of patients with heart failure. If I remember correctly, Nancy is what your role is. But in the Colorado ACC, I would say Nancy is one of our true anchors for the CVT team. And one of the greatest things that I've been able to glean as a true professional benefit has been getting to know people like Nancy and watch her advocate for our patients. I've legislative conference a year ago. We had a great time. So with that, Nancy, it would make sense that you will talk to us about safe and well-being, because you're someone who cares deeply about people's well-being. Thank you.
Thank you, Dr. Cleveland. And in the face of running a little behind, I'll try to keep things real brief. I'm going to introduce our main speaker, Dr. Stephen Berkowitz. He's a professor of psychiatry at the University of Colorado, and he's currently leading the department's COVID pandemic response. Dr. Berkowitz, would you share with us what you're doing over there at the university?
Yep, and I'm going to share my slot, I can get that going. Well, I guess it's good afternoon, everyone. It's hard to follow up some of what I was just listening to and the personal experiences. What I'm gonna try to talk about is how we can take care of ourselves. You know, we all know that if we're not doing well, then it's hard to treat our patients effectively. So these are my disclosures. I know this is, you know, kind of basic, but I want to just say that these four things are crucial to our ability to cope and manage, and that many of us are not doing that. So particularly right now, recent surveys suggested about 70% of physicians and nurses are experiencing sleep disturbance. You know, our stress levels are very high. About 40% of physicians are considering retiring. And so this is, we're under significant stress. And I would say the issue around sleep is really one of the more important ones. I also want to mention that humor is really useful. Laughter goes a long way, and there's an inordinate amount of data supporting humor and laughter as a major aid in reducing stress. So read those memes that are going around, even the ones that you might not like, but a good funny meme can go a long way. I want to say that this is really important. None of us are doing as well as we would like to be. Everybody you talk to, when they're honest, might talk about more fatigue or making more mistakes or, any number of things. And so one of the really key things for us is to accept that it's okay to not be okay right now. And we have control over that. It's our expectations are one thing that we have a lot of control over. And so they can create stress. But I want to just say we're beyond COVID in terms of the number of stressors that we're dealing with. And that's one of the reasons that we can't think of ourselves as being okay. So here's the list. And this is just a list I came up with in 5 minutes. If we had a discussion, you could add another 20. But we are living in absolute remarkable times in terms of all that we're struggling and dealing with. And in some ways, COVID has given us time to recognize some things that we may not have recognized before, and is increasing the stress level. I want to just talk about, I know this is a professional organization, but coping and stress reduction actually begin at home. It's your family, your friends, and those that you care about. That's where it begins, and that's where, if you can get some organization and some ability to do that there, your work life will be much better. So this is my major point about home. Chunk off 2 weeks at a time. Don't try to plan and do too much. Yes, you want to plan ahead for the future, but it's really good to think of life in about 2-week chunks. Maybe the COVID, recovery period, but that, and that in your family, with your close friends, make a real plan to schedule and talk and innovate together. Nothing's immutable, but try to do that and get creative, with your kids. One of the big struggles everybody is struggling with, either the hybrid or the online classes. Think about a way to make it, to really make it more creative, and also to let some things go when they're not working. Create friendly competitions among friends and family around things. I don't suggest sports betting, but you can do that. Particularly don't bet if you're a Broncos fan. This has came out of research that a number of us did post-disaster, and it's really 5 key elements for disaster recovery. I modified this somewhat for pandemics, because pandemics and disasters are not quite the same. But the key elements here are having a sense of safety, capacity to calm, social connectedness, a sense of future, and a sense of efficacy. And I want to say that subsequent research has really shown that the 2 most important areas are connectedness and feeling effective. So those 2 things hold, while the others really do matter, those 2 really hold up as being the most important things to coping, managing, and being resilient. So safety, it's complicated, but and particularly these days with media and all that's going on. But, try not to to inundate yourself with the news, with the media, all that's going on. Try to stick to, one reliable news source that you like rather than, bouncing around and hearing different messages and so on. Make sure that small circle of friends that you have and family that you think are level-headed, that you can have real conversations with, check in with them regularly. I know none of us are very good at this, to give yourself, the corona free zone time. Check your emails at the beginning or end of the day or both, but not all the time. And a space to not have to think about everything that's going on. And also, give yourself permission to say, I'm fried. I'm not doing well. And so that, you may spend some time saying it's about me today or my family in some window of the day. And, take that time off. We're, as physicians and healthcare providers, we are some of the worst patients, and we never follow our own advice, and myself included. But take that time for yourself. It really goes a long way. When you want to, try to get yourself to feel calm, do things that you find relaxing, whether it's the shower, taking the walk, calling a friend, watching something funny, getting out in nature. We need to do those things. Make sure you get out of your house and your office, even if it's snowing. Yes, we will be having snow at some point soon. And then enjoy it. Look for the evidence of life, or make it a scavenger hunt with your kids and your family. Take a look at the change in the seasons and how I actually have a maple tree that outside my yard that is starting to really turn color, and take a look at that. Movement and exercise, we will all know. And that exercise decreases our arousal systems and lowers stress hormones and is good for immune functioning. I do want to say something about that. In the survey, the AMA survey that many of you took, Coloradans' answer to their mental health needs was exercise. And while exercise is really useful, sometimes you need more than that. And so if you're really struggling, you need to seek help. Exercise is not sufficient. And then also, for calm, sleep, as I mentioned, is crucial. And really focus on, making sure that your sleep is okay, that it's doing well, and don't be reticent to get support or treatment or intervention for sleep, whether it's medication or some of the treatment approaches. But poor sleep really has a negative impact on our well-being. And then also just that opportunity to breathe, to take those stress-free moments, looking out a window, paying attention to your breath, enjoying what's out there, what's in your life. You all know how to do, I believe, the relaxation breathing, but when you're in your office and you're working hard, you're in front of multiple Zoom meetings, it's a good way to help yourself calm and feel better. And then efficacy. Efficacy is feeling empowered, engaged. Putting a plan together is efficacy. Providing your service, being a physician, doing well at it. But also it's important to start close to home, as I mentioned. And so making those plans and home projects together, again, working well, doing your job, making menus, making donations, all those things that we can do for other people can go a long way to feeling effective. And recognize that you're effective. One of the things I think we often do as physicians is this is just part of what we do, right? It's our job, but it's okay to give yourself some recognition for doing the job well done, taking care of a patient in any way, shape, or form. When we get to connection, we're social animals. We need connection. So do your best to be connected in a safe way. And really, that's just essential for us as human beings. And the more we can do that at work, at home, however you want to do it, is just essential. I think about our, pre-COVID, pre-pandemic, when we had issues, when we had concerns, we gather, right? We gather for funerals, we gather for memorials, we also gather to celebrate. We like to gather and be together. So to figure out ways to do that through your work, through your home, through your friends in a responsible way is really important. And it's so easy not to do so these days that it really takes an effort. And then having a sense of future is also really important. We don't know when this is going to end. We don't know when we're really going to get the kind of vaccine that we're looking for, what the next phases are. So again, make plans that for yourself and for your family. Start thinking about the holidays and even Halloween decorations and how you can do that with everybody. Get your children, develop a time capsule about their lives and your lives during COVID. Share stories with one another that are encouraging about the future. Lists of things to do things for others, get out there and really just, have the sense that this is going to be different. We're going to see changes, but there's a future and we plan for our futures all the time. Routine is really important for all of us. One of the dilemmas is how do you routinize when you're when you're sort of having these hybrid models. So think about how to keep your daily routine and structure, having clear expectations about how you're going to be safe, how you're going to keep your family safe. Let your families know when you're working and when you're on shift and what the plan is. And then, try to check in with your family on a regular basis. Do a 5-minute check-in with your family. And by the way, with your work colleagues, if you can do that. So in conclusion, this is one of the memes I found that I think is very accurate. Thank you, and I hope this was helpful, and I guess we have time for a few questions.
Dr. Berkowitz, that was maybe the best presentation of the morning. Thank you very, very much. That was excellent. We also have on our panel Dr. Katie Morrison and Dr. Abigail Lara. Dr. Morrison is the wellness director at the University of Colorado. And Dr. Morrison, I have a question for you. I wonder if, are you on?
I'm on.
I wonder if you would tell us a little bit about some of the steps that are taking place over there in the Department of Medicine to try to promote well-being for faculty and staff.
Sure, I'd be happy to. So first of all, I'm the director of the Wellness Initiative for the Department of Medicine, and it's a department of 2,000 people with 16 different divisions. And we started kind of building wellness initiatives about 1.5 years ago. And fortunately, we decided at that time before COVID to focus on community and connection. Our chair is leaving, and we felt like that was something that we could kind of continue forward. So at the time, we created Weldom at the Table groups, in which we paid people to go out to a meal once a month and go through a resilience curriculum together. We created Balance groups, which are kind of a clinician support group. We put together a website, and we also, probably the most important thing is we created a group of Weldom champions. So there's 16 different divisions, and each division is incredibly different from each other. So trying to figure out what's wellness for one versus another was really hard. So we pulled wellness champions from the 16 divisions. We tried to get everybody. So we wanted faculty, staff. Our faculty includes APPs, physicians, and researchers. We met for the first time on March 2nd, 2020, right before COVID. And we were trying to teach this group kind of human-centered design principles to try to bring about change. And so at the first meeting, it's like, look, you're all volunteer. You don't have to do anything except for communicate up, what's happening, and communicate down. And then COVID happens, and we're like, okay, actually, we need you to do something. And we need you to create community and connection. And so what was amazing was within, a month, these Weldom champions, there's 40 of them now, created about 26 different programs within their divisions. And they range from everything from, morning check-ins with the group to salons at night where people would teach classes about cocktail making or bread making, to book clubs, to blue zones, all this stuff. So our Weldom champions really put together this incredible network of community. Since COVID happened, we did a survey right in the beginning of starting our initiatives, and we did another one recently that really showed two things that were concerning to me. One is that our APPs are really struggling. There's like a 79% burnout rate in our APPs. And then also the other thing that's concerning is among our researchers, there was a higher rate of suicidal ideation. So at this point, we just kind of found this out. We're going to start focus groups among those groups to see kind of how we can help. So those are just some of the things that we're doing. We have a lot of other programs, but I also want to give other people some time. So.
Sure. Wow, that was like perfect timing to put into place the things you were learning, and then all of a sudden, oh my gosh, COVID was upon you and upon all of us, and you had to go from virtual to reality. Really, that's amazing. Thank you for sharing. Dr. Abigail Lara is the professor of medicine at the University of Pulmonary Sciences and Crit Care. She, I was hoping, might give us a frontline perspective while she's working in the university. She created some decision aids and helped schedule some optimized critical care programs for the overburdened frontline. And so, Dr. Lara, could we ask you to talk a little bit about your frontline perspective?
Yes, thank you so much for having me on this fantastic panel and for giving me the space to share my perspective. I can certainly share it from a couple of different lenses, not only as a pulmonary and critical care physician, as an intensivist that worked early on our surge COVID ICUs, and in leadership roles and how I participated at UC Health and within the School of Medicine. And to share my perspective of what it was like as we were taking care of these patients. So I can't believe that we're 8 months into this pandemic and recognizing that our life has changed so much. And I was sharing with my medical residents yesterday, I happen to be on service right now, we were having an ethics talk about how our life has changed, and there's a part of us that all grieve about the life that has been lost and our experiences that have been lost, not only as individuals, as we participate in society, but also as healthcare workers. So this is a timely discussion. So I echo a lot of what has already been shared about the patient panelist about how challenging it was to take care of patients when families were not at the bedside. I think that was one of the absolutely most stressful changes that we had to make within the hospital. We developed these policies to decrease exposure not only to our healthcare workers, but also to the family members. So being on early in the surge ICU, being at the bedside, holding a patient's hand because I had to substitute for a family member. And I am absolutely no substitute for any family member for sure. That was incredibly challenging, and I'm so appreciative of Kathy Morrison and her group in palliative medicine and our spiritual care. They were able to develop an incredibly strong communication support for our families and take some of the burden off of not being at the bedside. So they created, they developed a process by which we were able to get iPads to share with the nurses so they could hold as sort of FaceTime so our families could see the patients. And that was really, really important. It was absolutely no substitute for face-to-face physical presence at the bedside, but I think it was a huge, huge, huge improvement on what we were having. As I think about my experience and talking about resilience, which is very timely with Steve Berkowitz's outstanding presentation, and thinking about burnout as a pulmonary and critical care physician, probably one of the highest risks for developing burnout, just period, before COVID, and certainly I've experienced burnout now as an intensivist, but I think I've allowed myself to not only recognize those emotions and those feelings and recognize that if I didn't have them, I think I'd be a little bit worried about myself as a provider. I was incredibly grateful for leadership at UC Health and within the School of Medicine and in all the departments in regard to putting together policies, processes, and programs at the system level. So that way the frontline providers really didn't have to worry about what the process we had to follow. A huge component of psychological safety that we had very early on is the very effective communication that we had from hospital leadership and school leadership, specifically about PPE, so personal protective equipment. I can share with you, one of my dearest friends is a pulmonary and critical care physician at Mount Sinai, and there was at one point where she was putting on a trash bag because there was no PPE that was available on an emergent basis for her to take care of patients. I did not have to worry about that. So I have gratitude to leadership that really had the foresight to have that available for us. It was absolutely amazing to see multidisciplinary approaches to developing the processes for how we took care of these patients. My colleagues, not only in the critical care section, in the division of pulmonary, but also in the division of surgical and anesthesia critical care, we all came together, we banded together to really provide our the best care possible for our patients. And I think that that's exactly what Joe Cleveland is alluding to, the fact that 80% of our patients on ECMO survived. That tells us that all the work that we did really created a space where we were able to practice at the top of our clinical scope. We learned a lot from our colleagues on the East Coast and West Coast, and I think that Colorado had that luxury of being able to learn from what was happening on the coasts. Aspects that contributed to a lot of stresses and a lot of the fear that I saw and I witnessed, not only for nursing staff, respiratory therapists, physical therapists, and providers, was just the fear of the unknown, the fear of, and the fear of exposure. A concern that we saw early on, and we're learning quickly how to manage, was that we were being inundated with information of the experiences of what these patients, what their natural history was like. So certainly within my division, we focused on what was known from a critical care perspective. Patients develop COVID ARDS. We knew how to manage ARDS. We have all sorts of medical publications and best practices. So we wanted to focus on the care of those patients by using what was known and trying to avoid as much as possible the anecdotal medicine or depending too much on case reports. So I think that was very critical that for all of us in the front line, we really focused back on what our funded knowledge is and what our best practices were in taking care of these patients. I cannot highlight enough what Steve was saying about making sure that we take care of ourselves. When I'm on in the ICU, my family, my friends know that I am on in the ICU for my patients, but getting away when I'm home, I'm also very much home, because recognizing that we are still in this pandemic where it started the flu season, my ICU census is exploding. And certainly we're seeing an uptick in our COVID numbers. So when I'm here, I want to practice at the top of my game. And so being very thoughtful of taking care of myself and taking care of my family and of course my colleagues. Peer support is so critical during this time. And certainly my role in leadership in the School of Medicine, that's a really important component that I'm certainly seeing, as Katie's alluding to. People are getting tired, we're getting burnt out. And we need to be very thoughtful and kind to each other during this time. Something is, that hit home for me recently is as we started in the surge, with the surge in March and April, and all of us that were working in our COVID ICUs, we have our respirators, we have our PPE, but we also recognize that it wasn't necessarily a matter of if one of us would get sick, it was a matter of when. And recently, one of my colleagues had to be admitted for COVID pneumonia. And it was incredibly powerful and emotional and stressful to support my colleague through this process, and incredibly scary. She's on the other side, which is fantastic, but I can tell you that in the hospital, we have this amazing family of critical care nurses, floor nurses, respiratory therapists, physical therapists, that all contribute in a very multidisciplinary fashion to provide the best care that we can for our patients. My colleague has benefited from that. And I think that, it's a stressful time, but we will get through this. What the other side might look like, I'm not sure what the other side will look like, but I know it will be different. And I just appreciate what Joe said earlier. Absolutely wash your hands. Continue to wear the masks, socially distance. It's the only way that we're going to be able to manage this and eventually see the light at the end of that tunnel. So thank you. And
Dr. Laura. Thank you, Dr. Morrison and Dr. Laura and Dr. Berkowitz. I wish we had like another 20 or 30 minutes because I so many questions, and I sense that our audience has questions as well. But I think for this time, our time is up. Thank you so very much. I'm going to turn this back to Dr. Cleveland.
Well, thank you, Nancy. That again, I tell you, Abby, Steve, Nancy, and Katie, that was just really good. And again, reminds us that, we are, in the midst of this, but we're also human. We're just so, we've got to stick together. And I moved it. With that, I'm going to turn this back over to Dr. Carter. He's going to give us a teaser because as good as this has been, we're looking to make this even better in December. And we realize we had some glitches today with some of the technical things, but I think like all things, we've been able to get a tremendous amount of educational opportunity. While we're not together, to Dr. Berkowitz's point, we're still connected and we'll never lose that. So James, why don't you take us home and let us know what we have to look forward to in December.
Thank you, everyone. This was a fantastic first step. My little computer glitch notwithstanding, I think that because of the reaction to this last segment, we will revisit this issue in the spring, and we will figure out how to make that more top of the mind for us to have a a more robust discussion. For our next meeting, December 12th, we will focus a little more narrowly on atrial fibrillation, although there's overlap with what we discussed today. And we will take a foundational science approach as well as a clinical experience approach. And we will, as we learned today, it's quite important to try to reach out to the patients we serve, and we'll try to do that again. I thought that was powerful and remarkable. Everyone did a great effort today. It showed in the presentations. The one presentation where there was no audio, there will be a webinar recording that will have the audio. So there will be an opportunity to look back over these great lectures from Dr. Altman, Dr. Williams, Dr. Pappas, and others. So thank you again. We'll close now. And Joe, thank you for your leadership. Leanna Collins, you're fantastic. You tried to save me from myself, and I missed the lifeline you sent me last night. So this was definitely not on you. This was on me. But thank you for your efforts. This was fantastic. Thank you to the panel, panelists, and the participants. You'll receive more communication about our next session in December.
Excellent. I do want to acknowledge Leanna Collins. We've not seen Leanna's face, but the chapter could not run without her. And Leanna, as always, we do so deeply appreciate your incredible commitment to our organization. So I didn't want to, sorry, James, I didn't want to step up, but I just wanted to make sure that we completely acknowledged who really is 85 to 90% of the heavy lifting and day-to-day work for all of us to be able to do this. So thank you, Leanna. Thank you, everyone.
Thank you. Have a great day. Relax, everyone, and stay connected.
Thank you all.
Thanks, everybody. Great meeting.